Good morning, Mr. Gale.
Good morning, my lord. My lord, the first witness today is Mrs. Esther O'Hara.
Good morning, Mrs. O'Hara.
Good morning.
When you're ready, Mr. Gale.
Thank you, my lord. Mrs. O'Hara, your full name, please.
My full name is Esther Marie O'Hara.
Your details are known to the inquiry as your contact address as well. You've provided the inquiry with a detailed statement of your evidence. The reference to that is SCIWT 0381 and then 501. And as I understand it, you are agreeable that that statement be published.
Yes.
And that the evidence that you give today in amplification of that statement will be broadcast and recorded.
Yes.
Thank you. Now, you are a clinical specialist speech and language therapist with Greater Glasgow and Clyde Health Board.
That's correct.
And you have a specialist field within that discipline, and that is the treatment of cancers of the head and neck.
Yes.
You're presently on secondment to Unite, the union.
That's correct, I am.
And during the pandemic, you were the convener for Unite within the Greater Glasgow and Clyde Health Board branch.
I was.
Can you just explain briefly what that involved?
The convener is a role that is an elected role, so the workplace and other representatives of Unite the Union within a particular branch have the entitlement to elect a convener. That convener must be a rep themselves, and the convener's duty really is we're responsible for the reps, but also to the reps. So we're responsible for ensuring that the reps are properly trained, that we support them properly. My role involved giving them support with difficult cases, giving them advice, signposting them, etc. And because the convener tends to be one of the more experienced reps, the convener will also pick up some of the more difficult and challenging cases.
Thank you. You provide us with a note of your personal background, paragraph 8 of your statement. And we can see that you've been in the speech therapist profession for 38 years.
I have. 39 years come December.
Right. And you provide us with an overview of Unite and its activities, and we can read that, and probably many of us are familiar with it anyway.
Yes.
We note from paragraph 13 that the Greater Glasgow and Clyde Health Board, I'll just call it the Health Board for shortness in future, has some 40,000 staff.
Just short of 40,000, yes, that's correct.
I think you've said that between 2,500 and 3,000 of those are Unite members.
Yes, nearer 3,000. I checked quite recently.
And perhaps you've touched on this a little bit. What was the convener's role during the pandemic?
The convener was, I guess, the if you like, main coordinating person. So within Greater Glasgow and Clyde, we have a number, approximately 60 staff side representatives, most of those workplace representatives, but we also have health and safety representatives, equalities reps, and so on. So the convener is the person through whom any cases that are brought into the Unite office in Glasgow are distributed out and allocated. And during the pandemic, we had a big upsurge in phone calls and contacts made with people looking for advice about various situations that had arisen. Those, unless members came directly to a rep that they knew, those would generally come through me. and I would then allocate those to the appropriate person to pick them up and deal with them. And obviously, if it was something that was within my own constituency of speech and language therapy, then it would be myself that would pick up. But there are a number of other workplace representatives in speech and language therapy that I could delegate things out to if required.
You have provided us with a note of the pre- and post-pandemic situation as regards Unite in paragraph 16 to 18 of your statement. You say in paragraph 18 that the convener's role was very busy pre-COVID and still is now.
Yes.
That rather begs the question that during COVID, I take it there was a considerable increase in your activity.
Absolutely. As convener, I was given what's called facilities time, so I had 4 days of facilities time to carry out that role and another day to maintain my clinical role. However, I think it's fair to say that even pre-pandemic, it really is a full-time job and then a bit more. And during the pandemic, the upsurge in workload and issues that had to be picked up, distributed, dealt with, advice given, etc., really increased quite considerably. And to kind of put that in context, and I have mentioned it in my statement, I keep my own record of any additional time that I work.
Yes.
And pre-pandemic, that was sitting at, I believe, 99.5 hours that I had worked over and above what I was contracted to work. For staff side, I had a separate one for clinical work. At the end of the pandemic, that was sitting at 270 hours. So in the course of the pandemic, that increased several times over.
Yeah, we've got that at paragraph 24.
Can we be a bit more precise about the course of the pandemic is possibly controversial or contentious tag. The extra 273 hours would be over what, 2 years, 3 years?
Well, I measured that time
days?
from the start of the pandemic. I measured as being March of 2019.
Yeah.
And I drew the line under it
March
at,
2019, 220.
220, sorry, yes, you're quite right,
No,
220.
That's all right.
And
220, yeah.
I kind of, the point at which I measured the 270 was at the end of June of 2023.
That's fine, that's good. Thank you very much indeed.
Thank you, my Lord. Just looking at paragraph 18 of your statement, last sentence, you say, I'd summarise and say that there is more work now than there was before, but the balance of the work is slightly different.
Yes.
Could you just give us a little context of that, please?
Of course. So when I say that there's more work now than there was before, before is referring to pre-pandemic, yes, because obviously things overtook us in that approximately 2-3 year interval. There is more work now than before because there's a lot of catch-up work. So during the pandemic, from the staff side trade union perspective, a lot of ongoing work was parked because in the scheme of things it wasn't as important. So, for example, service restructures, initiatives the board were trying to take forward, partnership policy reviews, development of various groups to take forward pieces of work. All of that was deprioritised. On emerging from the pandemic, there has been, particularly in the early stages, a tidal wave. I've described it as, and I would say there was a tidal wave, and still it's maybe not quite such a high tidal wave, but there was a sudden drive to start picking up all of these things all at once, things that had just been sitting and hadn't been concluded. There were also workplace and HR processes that had been parked. So perhaps, for example, disciplinaries, grievances, all of that kind of stuff had been sidelined because there were priorities for management, HR and the unions because of the pandemic that meant that those were of lesser importance. But all of these things have timescales to them, and the timescales had been well exceeded, and so there was a push to start picking up a lot of this kind of work. And we still haven't caught up with all of it, so that pressure is still there.
Thank you. Paragraphs 19 and following, you deal with a subject that we are becoming very familiar with, and that's guidance. And I suppose you operated, if I can put it this way, as a pivot between guidance coming from others, such as the Scottish Government, down to the management of the Health Board, and then getting that guidance out, interpreted, and to your members.
Yes.
You have told us quite a lot about that situation. During the pandemic, if you can summarize it, what were the principal issues that arose, so far as you were concerned, in the receipt and issuing of guidance?
I would say probably the principal challenge, well, there were several challenges, but the principal challenge was the flow through of that information in terms of the number of guidances that were coming through. They were changing sometimes daily, sometimes twice, and occasionally even 3 times in a day. Our members were finding that very, very difficult to keep up with and to apply to their practice, because what they read in the morning might not have been what the guidance was in the afternoon, or what they read on Monday wasn't the guidance that was in place by Thursday. So people were finding that very difficult, and they were frequently coming to the trade unions and asking, what am I supposed to do in X situation? What is the current guidance? So we found that quite challenging, because of course we were faced with the same fast flow through of information. I would say some of the other issues really were around things like some of the guidances coming through that seemed to those of us, and I'm now speaking from a clinical perspective, that seemed to be ill-informed or based on a poor understanding of tasks that were taking place at the coalface. And, you know, I do have some examples of that from my own clinical practice. So as trade unionists, we tended to be the people who would challenge at local level and through our regional officer up to Scottish Government level, where we felt that guidance that was coming through was not really addressing some of the issues.
Was the problem that you're identifying that the guidance was put in terms that were general, but then having to be applied to specific situations and specific professions? Yes,
I would say that guidances that came through appeared to be written in a one-size-fits-all style, and that was not necessarily the case or the experience of people at the NHS coalface, as it were.
You make the point at paragraph 87 of your statement, in the hopes for the inquiry, the point about communication. And I think this is reflective of the concerns that you had about guidance. And perhaps you would could you just read out what paragraph 87 says, please?
Sure. Paragraph 87 says, I would encourage robust and effective communication. Whilst I appreciate things change and there may be a need to revise what's been issued, I would beg the powers that be not to be sending out 3 updates in the one day. This leads to confusion. Make it clear who the information is for and what it means for people.
You put it in quite strong terms, I would beg.
Yes.
I take it that that's reflective of a very strong feeling on your part.
Yes.
That that's something that should be done.
Yes, very much so. It was very frustrating as someone trying to give advice to members. That was the best advice I could give them, to have that advice being constantly revised, and sometimes finding myself wondering if the advice I was giving was the most recent advice, whether that perhaps I had missed a memo, because I was doing a clinical job as well as my trade union role and was very busy and often didn't have time to check and see what the latest core brief was that morning or that afternoon. So it was a challenge for me too.
Paragraph 22 of your statement, you say that as a sector, we were not consulted before any new guidelines were released. I take it as a sector you're talking about, as a union.
Yes. Health is a sector within Unite. It's one of 20 sectors.
Yeah. Was that any different from the situation that existed pre-pandemic if guidelines were being issued? Would you be given an opportunity to be consulted and make representations?
I would say that probably was it depended situation. Right. Lots of guidance comes down from Scottish Government, and although people at my level, at local level, might not have had sight of that, we would anticipate that our regional officer, for example, would, through the connections that he has in the meetings that he has at Scottish Government, that he would be able to input and try and if you like, mould the guidance that's coming out. And what I would say is that our particular regional officer is very communicative, very hands-on. So he would certainly be communicating with people like myself as convener and our senior reps team if there was something that he was aware of that he felt he wanted a local view on. And we also, within Unite, have a regional industrial sector committee for health. And that's the decision-making body within Scotland for Unite about what our position is on various things. So I would anticipate that through the interventions and offices of a regional officer, that committee would be involved in the discussions about any key pieces coming through. At local level, within the health board, I, as convener at the time, sat on what's called the Area Partnership Forum, and that is, as the label says, it's a group consisting of board members, management, HR, and the various trade unions who are represented within Greater Glasgow and Clyde Health Board. And local policies and decisions would come through that group, and staff side would have input at that level.
I suspect the question that I'm going to put to you might, and I apologise in advance if it does, might step on toes of things that Mr. Gale is going to ask you later on in your examination, but it seems an appropriate time to ask it, so with that apology. I suspect, Mrs. O'Hara, that you probably agree, I think most people would agree with the proposition that in a critical situation of an emergency, such as a pandemic, situations which require guidelines may change more quickly, in fact probably will change more quickly than they would in normal routine times.
Yes, I think that's fair to say. And while it was challenging, I think we all recognised why it was happening. The scenarios were changing very quickly, new information was coming out very quickly, and I fully understand that the guidances that were coming out for a reason. But the reality of that was that it became very challenging for people on the ground, staff trying to deliver care, to keep up with what the latest guidance was. And I think it's fair to say that staff were concerned about potential implications if the practice they implemented was not in line with the most recent guidance and there was a mishap or an infection or whatever. People were worried about being held responsible for that if they had acted on the guidance that was 2 days old, that was the most recent one they were aware of, because for whatever reason they hadn't seen the most recent one.
Now, rest assured, I appreciate that. We've already had evidence about that. You're anticipating the wrong light in my question. The question that I was going to ask proceeds that if there had been, and I'm assuming at the moment that there may have been defects in pandemic planning, so I'm putting that assumption into it, but if there had been more, I'm not sure exactly how to characterise it, more comprehensive, more efficient pandemic, more comprehensive is probably the better word, pandemic planning, then it may have been that some of the issues which resulted in rapid and frequent changes in guidelines might have been covered by more comprehensive and full guidelines had they been prepared better in advance. Would you agree with that proposition?
Yes, I would. My impression was that particularly early in the pandemic, there was a lot of knee-jerk reaction type information coming out. And I can recall a couple of instances where there almost seemed to be a slight backtrack. We had a guidance, then we had a different guidance, and then we would, at a point down the line, go back to what the earliest guidance had been. Well, not the earliest, but earlier guidance. So there was a lot of shifting, but I do understand why that was happening.
Thank you. I'm sorry if I stepped on your toes, Mr. Gale.
No, my Lord, I'm very grateful. Just on that, Mrs. O'Hara, you do tell us in paragraph 22 that the union that you were part of, you say, were very vocal if new guidance was released and we did not agree with it.
Yes.
So you were able, as it were, to advocate your position fairly quickly, as I understand it.
Yes.
What you're saying.
Yes.
And as a consequence of that, did that on occasion lead to revisal of the guidance?
In some cases, yes, ultimately. I would say that wasn't a quick process necessarily. Right. There were occasions where we had concerns about particular issues and raised those either through the risk, through a regional officer to Scottish Government, or at local level to the Area Partnership Forum. And we did manage to effect changes of direction, but it sometimes took more time than would have been ideal.
Can I ask, put this question in rather a general way, rather than looking at a specific example? Did you come across instances where the guidance clearly proceeded upon a misapprehension or a misunderstanding of the circumstances of a particular profession to which it had the potential to apply?
Absolutely, I can. As a speech and language therapist, and I'm speaking from a clinical perspective now, a lot of the work that we do is around people who have swallowing problems for various reasons. Yeah. Certainly in my own clinical field, that's very much the case. In assessing these patients, you're in very close proximity to them, and often the first symptom that someone has a swallowing problem is that they cough when they eat and drink. And in assessing them to see what's going on with their swallowing, to try and work out at what stage in the swallow process things are breaking down, and whether there are manoeuvres or things that we can try and minimise the risk of chest infection and ultimately pneumonia, you have to test the patient and introduce foodstuffs and fluids. And if the patient has a swallowing problem, they are going to cough, and they're going to cough quite close to you. In my own clinical practice, I deal with head and neck cancer patients, many of whom breathe through a permanent stoma in their neck. They don't breathe through their mouths anymore. And in order to be able to voice, and without going into a long-winded explanation of the anatomy and how the valve that we use functions, speech and language therapists will insert or change a prosthetic valve that sits in the back wall of the trachea. And in order to do that, you're literally less than 6 inches away from the patient. You are introducing pieces of kit and using forceps, etc., that inevitably cause the patient to cough, and sometimes to cough very, very profusely. And you are in very close proximity. And I have previously, prior to the pandemic, had instances where that coughing was so profuse that I had to go and change my uniform and try and wash my hair because there was blood and sputum, etc., despite any PPE that I might have had on. So our view as a profession and our professional body were very clear that this was a high-risk procedure, and that swallowing assessments in general were risky because patients were going to cough, and that these were aerosol-generating procedures. and the guidance from Health Protection Scotland, originating in Health Protection England and come down through government and through all the various levels to get to people at my level doing the job, was that this was not an aerosol generating procedure and that we did not require full PPE in order to carry out swallow assessment or even the valve change procedure that I'm speaking about. As a trade unionist, I was very concerned about that. As a clinician, I was concerned about myself and the team that I have responsibility for. I have to say that local management within my own department were enormously supportive of us and took the position, and it was the correct position in my view, that these procedures, particularly the valve changing procedure, was not to be carried out unless we were wearing FFP3 masks and all the appropriate kit. So that was double gloved with a plastic apron on, with a visor as well as the mask. So that was a very sensible decision, but it flew in the face and was in direct conflict with the guidance that was coming officially to the health boards, that this was not an aerosol generating procedure. The only caveat around that was that we were told that if we were using suction, which we do occasionally use for valve changing, that would be deemed to be aerosol generating. And this was in a context of staff sitting at home watching computer graphics on the news about how the pathogen could spread if someone coughed in the supermarket. And we had people coughing right next to us, and in the case of valve change, literally 4 to 6 inches away from your face.
Now, this is an area that you give us specific information about, really, which reflects what you've just told us. It begins at paragraph 56 of your statement and goes on to paragraph 66. As I read what you say there was an obvious, from your perspective, disconnect between what should have been known and which was apparent to the experts in the field, such as yourself, and the more general guidance that was being given, emanating, I think, as you've said, from, well, I think some of it from the Chief Medical Officer.
Yes.
And do you feel, looking back, that even at the outset of the pandemic, that this should have been something that was realized specific to your profession?
Yes, I would say so. I would draw the comparison with, for example, dentistry, where, you know, they were, the guidance for them was very much that the work that they were carrying out was aerosol generating, and I would say in those contexts, and particularly around valve change where the proximity is so close and the coughing is so frequent and so violent sometimes, that the risks were not dissimilar, but the decision about what was and wasn't an aerosol generating procedure were not similar.
I think you described the coughing as on occasions explosive.
Yes.
Okay. Right. Well, thank you for giving us that detailed explanation. That's, I think, very helpful. Can I move on to talk about PPE? You indicate in paragraph 32 that one of the key and initial challenges of the pandemic was the provision of PPE, what was available, where it was located, what its quality was. And you go on to say, and this is obviously in general terms, but obviously informed by specifics, I assume, that there were less than ideal decisions made by management in prioritizing who got it and who did not. And then you offer your own personal opinion,
Yes.
which is that those in lower paid and apparently lower valued positions were less appreciated in this regard and were not prioritised for PPE. For example, porters and domestic staff. Porters were not seen as frontline staff, and in your opinion, this was foolhardy, unfair, and wrong.
Yes.
Now, that's obviously quite a trenchant criticism.
Yes.
Can you just give us a little context to it?
Of course. Within my team of senior reps, one of our senior reps is in fact a porter. And he, on several occasions, was in touch with me because the portering departments across the various hospitals were having significant challenges in being issued with PPE, particularly early and mid-stage in the pandemic. He was able to give me a personal example. So in one of our older hospitals, there are various buildings and connected by a very long corridor. And patients were coming into accident and emergency in one building, being examined, deemed to require hospital admission. Where COVID was suspected or known, these patients were then put on a trolley and had to be pushed by the porters from one building to another. And the connecting corridor is quite a long corridor, so it would take them quite some time to do that. And the porters were refused masks because they were told that if a suspected COVID or COVID positive patient that they were transporting coughed, the patient was facing away from them, and so they were at low risk. Now, if you think about the logistics of that, if the patient's facing forward and the porter's behind and the patient's pushing forward and the patient coughs, the porter's going to walk right into the air into which a COVID positive or suspected COVID positive patient has coughed. I do believe that the decisions that were being made at that time were being influenced by the fact that appropriate PPE was in short supply. And I think essentially decisions were being taken about if we only have a limited number of masks available, who is in most need of those. And as I say, I think it was a very foolhardy decision. We did have a porter that I knew well. I had represented him, who contracted COVID. His wife is adamant. He was a very well known, very likeable, very hard-working man who volunteered for extra shifts during the pandemic. And his wife's take on that was that he was never away from the hospital. He contracted COVID and died. And that was in the period where these kind of decisions were being made, that certain groups of workers, and in my personal opinion, and looking at what I was being told as convener, as the point of contact for all the people who had concerns, I think those decisions were being made along the lines of relative value of the staff role, and you know, if we don't have enough of them, we're going to give them to that group, but we're not going to give them to that group.
I think this is first of all, the example you gave, or you've given about the porter who sadly died, is something you tell us a little more detail about, and I don't want you to go beyond what you've told us, just in case he can be identified, so we'll leave it at what you've said, but we can find that at paragraph 51 of your statement. I think even to a complete layman, the idea of it being deemed to be all right for a porter to be pushing a patient and therefore potentially walking through whatever that patient has expelled from themselves might work if you were being stationary. I don't really see how, personally, I don't see how it fits with a moving situation.
Yep.
And I'm just comforted to see that somebody within a profession is of the same view.
Yes, yes.
A little bit about community health visitors. You refer to those professionals at paragraph 35 of your statement. And I suppose one of the difficulties with community health visitors is that they are entering a situation which isn't or doesn't have the discipline of a clinical setting, if I can put it that way. And what were you finding what difficulties were you finding so far as community health visitors were concerned?
I think the challenges for community health visitors were the same for all community staff. So, you know, again, referring to my own profession, speech and language therapists were trying to maintain services in as far as they were able to within the guidances as well. And for groups like health visiting and peripatetic SLT, there were challenges of availability of PPE, of where that PPE could be sourced. I did have one member of staff who got in touch to say that they'd had to drive across the city to pick up PPE and had been given one mask for the whole day. That was not a common occurrence, but it did occur. There were then issues of once whatever task had been carried out in the home, what were these staff, health visitors and others going to do with the PPE, because you know they were not for reuse, and it would not have been practical for staff to drive from a patient's home back to a health facility to dispose of PPE. And so the guidance that was given to them was just to put it in a bag and seal the bag and keep it in the boot of their car for 48 hours, because after that time it was deemed the pathogen would have died off, and then they could just put it in their domestic bin. I could understand why that was a cause for concern to these staff, because they didn't like the idea of potentially contaminated material, no matter how long it had been in their car, being put in their domestic bins. But also, you know, even allowing for the fact that people were not travelling in social context, or shouldn't have been. Situations could arise where these staff, and the reason I'm mentioning this is because many community staff in health services use their own vehicles. Situations could arise where they were with PPE in a bag in the boot that was not yet 48 hours you know, from use, and therefore potentially still contaminated. They may have to put their children in the car, they may have to put an elderly relative in the car, they may have to drive for many hours in the car themselves with accumulating bags of contaminated PPE in the boot. So I really could understand why staff were uncomfortable about that. And the other thing, which I haven't mentioned in my statement, were concerns about laundering what you were wearing and laundering it in your own washing machine. You know, whether that was a safe thing to do when you were doing laundry for other members of your family. So there were the concerns around all of those issues for community staff generally, including the health visitors.
One of the points that we have picked up in the recent past in the inquiry is issues about disposal of PPE. And while perhaps it doesn't necessarily, in the hierarchy of issues about PPE, present as possibly the most important, it is still a very important aspect with the risk of infection and reinfection.
Absolutely.
You do tell us about problems with substandard PPE in paragraph 36.
Yes.
And we can read what you say there. The one that I'm particularly interested in is the use of the availability of PPE with revised, if I can put it that way, sell-by dates.
Yes.
Now, you make the point, and I think with respect, it's one that probably hits home to, particularly to lawyers, that where you make reference to a manufacturer, 3M, and you tell us that where a piece of PPE is beyond the expiry date, or however one wants to call it, the manufacturer would, quite properly, I suppose, indicate that they would not take responsibility for the consequences of use of, in this case, masks that had expired.
Yes, that's correct.
Yeah. Now, you do give us an example of an incident that you were personally involved in, and you do that at really paragraph 37 and following. Just summarising, can you just tell us what actually happened?
Yes, I was made aware by one of the senior rep team who sent me a photo shot. He had spotted, because he was a frontline clinician himself, he was an AHP, and was required to use FFP3 masks. So these are the most robust, if you like, masks that were available, and they had to be personally fitted, etc. He had spotted boxes of masks, and because he was familiar with them, he realised that they normally didn't have a sticky label on them, that they normally, the expiry date of the masks was printed on the fabric of the box. He decided to peel the label off to discover that the masks were over a year out of date, and a new expiry date had been stuck over the top. So I thought that was really quite concerning, and so I raised that with the senior management team through my contacts at the Area Partnership Forum, and was told that this was perfectly fine and that the masks were absolutely fine for use. And that was because Health Protection Scotland said that they were satisfied that the masks were safe. And my reaction to that was, well, just because you say it's so doesn't make it so. Can I please see the evidence of that? There was quite a bit of toing and froing over a period of time. I was then told that Health Protection Scotland's position was based on Health Protection England's position, and my comment was the same. I need to see the evidence. The health board said that they would try and get the evidence, and eventually they did forward me a sort of, if you like, engineering report, and it was full of engineering speak. And the engineering report, because that's not my sphere of expertise, I was not sure what that report was telling us, but Unite were able to engage an engineer with that specific background who not only was familiar with standards but actually wrote standards, and his assessment was that the testing parameters were not stringent enough. And his particular concern, apart from the fact he thought the threshold was too low for when, you know, masks would be deemed to be suitable, the report stated that if one mask out of every consignment of 100 was tested and found to be sufficiently protective, then the entire box of 100 was deemed to be sufficiently protective. A colleague of mine, a trade union colleague, contacted the manufacturer, 3M, who gave us in writing a statement that said that these dates were there for a reason, and that it was their company position that when masks reached their expiry date, they could no longer be guaranteed to be sufficiently protective and should not be used. I fed that information to the board, and the credentials of the engineer concerned were questioned. I provided the credentials, and after a day or so of reflection, I was emailed and told that the health board's position would be that they were not going to withdraw these masks from circulation, but that if any member of staff requested and said they were not prepared to wear one of these expired but redated masks, and some of them were redated not just once but twice, that they would be provided on request with an alternative. However, the Health Board did not undertake to communicate that. And so it was left to ourselves in Unite to communicate that to our members. We shared that information with our trade union colleagues because we thought it was worthy of wider dissemination. But it's fair to say that not everyone in the NHS is a trade union member. So that information would not reach everybody, but we circulated it as widely as we could. And I believe that people did say that they didn't want to use those masks, and they were issued with an alternative, but it was on request only.
Was the Health Board made aware of the caveat that 3M had issued to you regarding the
yes, they were.
appropriate
I made them aware of that
use?
myself.
Right. And as you said, what they had said to you, and it may be that there's a commercial side to it as well.
Yes.
But that those dates were there for a purpose.
Yes, and what I would also say about that is, you know, the point was made to me that, well, it was in the company's best interest to sell that so that they could sell more masks. But the fact of it at that time was that they could not keep up with the demand. So, you know, I thought it was a flawed argument to say that 3M were trying to sell more masks when they didn't have any more masks to sell.
The point is made, Mrs. O'Hara, in paragraph 44 of your statement, that there was perhaps the perception that the unions were panicking over nothing and just making an unnecessary fuss, put it bluntly, being a bit bolshy.
Basically, yes. That it wasn't something that I came across from all management approaches that I made, but I did have reason to believe from time to time that there was an impression that the trade unions were just making a fuss because they could. And in actual fact, we were making a fuss because we were concerned and our members were concerned. And it's our role to raise those concerns and to try and protect our members as best we could.
We'll move on to another issue, and that's staff redeployment. You talk about this in paragraph 46 of your statement, and you give an example. We've heard a little bit from a number of witnesses about staff redeployment, particularly the concern that staff were being redeployed into areas for which they did not have the correct skill set. Could you explain the circumstance that you are referring to?
I can think of a couple of circumstances, but as speech and language therapists, obviously I've explained already, we do a lot of work around swallowing and swallow assessment. We were short-staffed. We had people who were furloughed. We had people, not furloughed, but isolating. We had people off. We had huge caseloads. We were running to stand still. And we were then asked to go and assist on the wards, if and when we could, over lunch times, etc., with personal care tasks. Now, personal care tasks, you might think, well, where's the kind of clinical concern around that? Surely anybody can do that. But those kind of tasks could involve, for example, walking a patient to the toilet. Now, if that patient falls, we're not trained we're trained in how to lift and move boxes. That's our moving and handling training. If a patient slips and falls and hurts themselves, there were concerns about how, and it wasn't just a concern for SLT, there were other clinical specialisms being asked to do similar types of tasks. But there was that question about if something goes wrong and we don't have the skills to deal with that, how does that affect us in terms of working outside our scope of practice, which is viewed very seriously and rightly so by professional bodies such as the HCPC and you know the kind of nursing professional body as well. So there were concerns around that. There were also concerns where people were in fact qualified to do a task that was requested of them, but perhaps were not sufficiently experienced. And I think the example that I've given in my statement was something I didn't witness, but I was made aware of it by a colleague from another discipline the next day. We have an open plan office, and she had witnessed a situation that arose. A very junior, very newly qualified member of our staff was working late, a temporary member of staff obviously trying to make an impression and do the job properly, and she was sitting doing her notes a good half an hour, 3/4 of an hour after her finishing time, and a manager appeared and instructed her that she had to go to accident and emergency to assess a patient's swallowing, because that assessment was all that was keeping the patient at the casualty department. And if we could assess the patient and the patient was fit to go, the patient could go home. The member of staff concerned was not asked, can you do it? She was just told to do it. She wasn't comfortable doing it because there was no more experienced SLT around had there been an issue that she wanted to seek advice on or get some guidance on. She went and did the task, but I was told, was visibly very upset. And I did take it up directly with line management the next day and was assured that it wouldn't happen again.
One of the other areas you tell us a lot about from your perspective as a union representative, but as an observer, about staff pressures. Mm-hmm. And you've told us quite a bit about that from paragraphs 49 through to 55. And again, these are matters that we can read about, and it includes the point that you made about the porter who died from COVID. So we have that. Just, again, it's probably something that we are now all well aware of. But I think perhaps coming from you as an observer, it's quite impactful. Paragraph 54 of your statement, you say that you saw nurses outside critical care, is it right? Units in tears on several occasions. Mm-hmm. This, again, we've heard about this from the RCN and indeed from other individuals. So far as those who were relaying issues back to you, what were the particularly emotive and emotional aspects of what people were doing at that time?
Yeah, I did feel very much for nurses, particularly those who were working in that kind of environment. They had many, many challenges dealing with very, very sick people in PPE for full shifts, which, you know, I had to wear it for 2-3 hours at a time, which was horrendous enough. So they had all those challenges. But nurses are, by definition, caring, as are all NHS staff. That's why we do what we do. And for these staff to be dealing sometimes with people that they knew, or to be dealing with people who were very seriously ill from COVID or dying from COVID when they knew people in their own lives who were in that same situation, and to have to do the mechanics of the nursing, but to be unable to do in the same way that they would normally have done the caring aspects of the nursing, the sitting with someone when you know they're about to pass away and hold their hand and be with them, when there were so many pressures and they had other patients to deal with, and the very PPE that they were wearing meant that they couldn't be as caring or be seen to be as caring. They were just a faceless, maskless person who was delivering the care, whereas what they really would have wanted to be doing was supporting these people in their worst moments and sometimes their dying moments. I think the mental impact of that has been enormous. We had, at the time, a staff side representative who was working in that context, and she shared with me over a coffee one day some of her experiences, and it was harrowing to listen to. And they didn't even have the same rest and recreation facilities. The health board was very good at making rooms available where people could go and have a cup of tea and kind of chill down for half an hour. But they couldn't leave the ward because of the nature of the patients that they had and the pressures of having so many of them who were so very seriously ill. And they even had to kit out their own rest and recreation area. This particular, as I say, she was a trade union representative, but also a very senior nurse, had to make phone calls to get armchairs and kettles and a water cooler and other kind of facilities, so that when there was a member of staff needing a break, be it because they'd been working for a long time or they'd just had a very distressing situation, there was a place that they could go and chill out. But they, as I say, they even had that challenge of having to kit out their own rest and recreation area. So my moving from our office building to where I normally have to go to deliver clinical care, I have to pass these units, and it was not unusual to see somebody standing outside crying into a hanky.
Now, because you've dealt quite fully with the particular challenges that your own profession had, I'm not needing to go through that in any detail. There's just one thing I would like to ask you about. Paragraph 61 of your statement. Again, you're talking about I suppose it's based on guidance or instructions. For one of your, either to you or one of your colleagues, a suggestion was made by one speech and language therapist manager that perhaps you could, or your profession could look at holding open air sessions, for example, in local parks.
Yes.
How sensible was that?
I could see that it was well intentioned, because although I've mentioned a lot about our involvement with swallowing, this particular scenario was around children with speech and language problems. And it's fair to say, as a speech and language therapist, and you may have seen reports on TV, that we are now picking up the consequences of lots of these children not developing normal language who couldn't have speech and language therapy during the pandemic because of the restrictions. So this suggestion was made. It didn't go anywhere, but I could see that the thinking was perhaps we could do something where safe social distancing could be maintained. But my thought at the time was, it's Scotland, it's cold, it's often wet. My specialism isn't in paediatrics at all, but from what I do know of it, and having had children myself, children in a park environment are going to want to go and play football or go on the swings. So their ability to attend to the therapeutic intention of any session in the park was never really going to be something that young children were going to be able to manage. So it was well intentioned, and I absolutely understood where it was coming from, but it just really wasn't practical at all. Finally,
Mrs. O'Hara, you do deal with some of the longer-term impacts on your profession, paragraph 67 and following. And one of those is that there was burnout. A lot of people retired from the profession because of what they'd experienced. And you do put it that that there was a feeling, I suppose, that some felt that they should soldier on for the love of the job. Is that something that might apply not only to your own profession?
Oh yes, absolutely. I think there is a perception in society that NHS work is a vocation, and that we do it for the love of the job. And we do it for the love of the job. We wouldn't be there otherwise, but we also do it because we all need to live. I would say within profession, certainly within my own profession, I have seen a number of colleagues of a similar age to myself and similar many years of experience and expertise who have either retired and not considered the option of staying on, or considered it and said, I'm not going to do that, why would I? And also I have known colleagues to go slightly earlier than they would normally have planned. And I do think that the stresses of the pandemic, the expectations that were put on staff, some of them, we understood, you know, this was an absolute crisis situation, but it went on for a long, long time. And while people can cope with a short-term crisis and then recharge their batteries, this was relentless over many, 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 many months. And there were staff who took the decision that it was time to go. We do now have a recruitment crisis, and normally staff would perhaps consider coming back, but there are lots of staff who are saying, no, I've done my bit and I'm not coming back.
Final point, and again something we are hearing about, is the backlog of work and the delay that may have occurred during the pandemic. And you, in your specialty of neck and head cancers, I think you make the point that you have experience of patients presenting late, and as a consequence, and within your area of expertise, requiring more extensive treatment and more challenging rehabilitation.
Yes.
And as you say, there are poorer clinical outcomes as a result of that.
Yes, that's absolutely fair, and that's a view held not just by myself or people within speech and language therapy, but it's a view that's been expressed by some of my medical colleagues as well. The difficulty was most of our referrals will come in through either dentists or GPs, and people were, during the pandemic, unable to get these kind of appointments. So where a dentist might routinely have spotted a cancer at an early stage, or a patient might have gone to the doctor and said, I've got a sore throat, and the doctor could physically, with the patient in front of them, look in and see that there was a lesion there that required investigation. Those processes were just not possible remotely, and as I say, dental appointments were for absolute emergencies. And the result of that has been that people are now presenting who perhaps could have been curable had they been picked up at an earlier stage, and now are either not curable, or their treatment, be it surgery or radiotherapy or whatever, sometimes both. The amount of surgery, etc., that they have is much, much bigger, which gives them much more challenging issues with speaking, with swallowing, and with issues that other people in other clinical disciplines have to pick up. And their outcomes, therefore, are not so good. They may have restricted diet, they may never swallow again, or they may be terminal. So, yeah, I think it's fair to say that the effect of the pandemic and people not being able to seek intervention at an early stage is now causing us challenges at a time when services are under pressure anyway.
Now, I'm conscious of the time, Mrs. O'Hara. You provided us with a note of what you think are the lessons to be learned, and also the hopes for the inquiry, and I've referred to one of them, which is at paragraph 87 about communication. So all of those matters will be taken into account. At this stage, can I just ask if there is anything that you feel that you would like to say in addition to what you've said, not in repetition, but in addition to what you've said. This is perhaps your opportunity to do it.
I'll try not to be repetitive. You know, my intention here today is to give my perspective as a trade union rep and as a frontline clinician who is not a doctor or nurse. And I think it's fair to say that good decisions were made. I don't want it to come across that every decision was a bad decision. Good decisions were made, but sometimes the good decisions were in direct conflict with guidance. There were bad decisions taken with no intention to harm, but often harm resulted, and it was down to the trade unions to challenge those. That was our role. We weren't there to make things difficult for management, but to challenge. So, you know, I think you've covered what I feel we need to learn. I think for me, the big thing is the NHS was not and is not in a state of readiness. And I do fear the once-in-a-century pandemic mentality, where we get one every 100 years and that's us had it now, so we don't need to worry about it anymore. In the modern age, with global connections, this could happen again at any time, and it could evolve and become very challenging very, very quickly. So I think it sits with the decision makers to reflect on what the pandemic has taught us, so that if, and I guess I should say when, because it will be a when something like this happens again, that the service is battle ready.
Thank you very much. My Lord, just in conclusion, I'm told that I gave the wrong reference to Mrs. O'Hara's statement. It should be SCI WT 0318. I think I gave it as 81. And then the usual five zeros and a 1. Is that right?
Suspect we can live with that, Mr. Hale.
I think we no doubt can, my Lord.
There is a typo on page 1 as well, but I've already flagged that to Thompson's. So
I'm sure we can live with that.
You're forgiven as well.
It over-exaggerates how many members we have in Greater Glasgow and Clyde. It's got a 4 and it should be a 3.
Thank you very much, Mrs. O'Hara.
Thank you.
Thank you, Mrs. O'Hara. Very good. Between 5 to and the hour. Thank you very much.
Thank you.
Now, good morning, Miss Traynor.
Good morning, my lord.
Now, are you ready to proceed?
I am, thank you very much. The next witness is Emma Currer.
Thank you. Good morning, Miss Currer.
Morning.
I wonder if you could start by telling us your name.
Emma Louise Currer.
And you are, as I understand it, the National Officer of the Royal College of Midwives.
Yeah, for Scotland.
You have provided a statement to the inquiry, and that statement, for the benefit of the recording, bears the reference SCI WT 0389, 5 zeros and then a 1. That's for our benefit. But you should understand that all of that information will form part of your evidence, and the inquiry will be able to consider it. There are a number of interesting matters which I wanted to pick up with you. But first of all, your statement tells us that you've been in your current role for around 15 years.
Yes.
And you also tell us, I think, that you qualified as a midwife in 1998 and you're still registered as one.
Yes, that's correct.
In your current role within the RCM, I wonder if you can give us an overview as to the responsibilities that you have.
So, in sort of mirroring the nature of the RCM as an organisation, I kind of have a dual role in the context that, from a Scottish perspective, I have a professional representation and advisory role in relation to maternity strategy, healthcare policy, advocating on behalf of midwives and our members and the maternity services and women and families. And I also have a role leading on our trade union side in terms of employment relations and representation of members in relation to regulatory or workforce issues.
And from your statement, we can gather that all of that really came to the fore during the pandemic period. I wonder if you can maybe give us a brief overview as to the particular role that you required to step into because of the pandemic.
I wouldn't say my role fundamentally changed because of the pandemic, but in terms of the weight of particular pressure shifted. So as an individual within our organisation, on a UK-wide basis, we very quickly formed a group called an Expert Clinical Advisory Group. So we recognised very quickly, based on the numbers of inquiries we were receiving, that there was no guidance specific to maternity or obstetric care. And we worked in collaboration with the Royal College of Obstetricians and Gynaecologists to produce an overarching document around providing care to women during the pandemic. But we also created a group of a number of individuals in our organisation coming from different backgrounds, where we sought to develop a number of guidance documents. So one of the key things that I was doing was writing, specifically leading on some and contributing to a number of guidance documents that we wrote that were specific to providing maternity care during the pandemic. And they went on to essentially a strand of our website that was dedicated to the pandemic and where resources were available, not just for midwives and maternity care workers, but also the general public. And we also formed a rota for responses. So the numbers of inquiries that we got absolutely escalated overnight, and a huge number of them came from the general public, which wouldn't ordinarily be so high, and we found ourselves having to respond to a number of these inquiries. So we had to actually form a rota to ensure that we responded to them all and directed women and midwives to appropriate information. In terms of the other element of my role, the trade union side of it, likewise, the number of inquiries and requests for advice and support escalated significantly. That also came via our workplace representative networks as well. Regular inquiries about what we should and shouldn't be doing in practice, what's safe to do, what's not safe to do, how do we manage these pressures, how do we interpret a number of things that were being given or being told, and escalating to us concerns about the pressures and what can be done about them. So,
in terms of the membership that you serve, I think you say at paragraph 5 of your statement that, without giving any specific figures, the vast majority of the midwifery profession in Scotland particularly are members.
yes.
You talk at paragraph 14 of a matter you just raised, which is essentially, you say, when COVID happened, the number of general inquiries we received from the public and employers, mostly pregnant women and mostly through your website, increased significantly, so much so that we needed to allocate existing staff to assist in dealing with these. Can I take it from that perhaps was a new thing, that the number of inquiries from the general public rather than just your membership?
Absolutely, yeah. I mean, we will always have a level of inquiry there, but it was significantly increased.
You go on to say at paragraph 15 that, like everybody else, you couldn't attend anything in person, so quite a lot of the work was moved online. You say things like disciplinary hearings and many aspects of routine business were put on hold unless they were of a very serious or pressing nature. And I wondered if you could tell me more about the impact that things like disciplinary hearings being put on hold might have had to the members.
That obviously anyone that's subject to a kind of work, a work process that involves scrutiny of their, practice or conduct, is going through an episode that's stressful for them, and they want to generally expedite that to the point that it concludes, and then they feel, they understand where they're at with it. To have that sit static for prolonged periods, particularly while they, in the large, continue to work through it, obviously maintained a level of anxiety and stress that we couldn't alleviate for them because we couldn't conclude a number of processes.
And I suppose you wouldn't have had an answer as to when you were going to be able to do that again, because you didn't know.
No, and even when they did begin to resume, they were no longer themselves conducted in person, which made those processes all the more challenging and stressful, probably.
I think within paragraph 17 you say generally that services being moved to online-based, providing support remotely doesn't mirror the in-person support that you provided prior to the pandemic. I wonder if you can tell us what the issues were with providing that online support. You mentioned their stress, particularly.
Yeah, I think for many of us in our day jobs, we regularly use computers and elements of IT functionality, and even at that, as we know, moving to online video meetings, even for those of us that had some experience and insight, became the norm. But for our coalface members, they were not used to working in that capacity and engaging in their role in that way, be it with other staff and health professionals or with patients themselves. So I think, arguably an anxiety around will the IT mechanisms work? Do we know how to work them? But also the person that they're engaging with, do they also know how to do that as well? And just the barrier that is perceived from not having that personal element of care, and it makes the communication more formalised, where actually you can get more out of more, hands-on, in-person communication with people.
You go on to talk in a general sense about there being a extraordinarily enhanced role for midwives and people in midwifery roles, and you say that those the role increased significantly, but the funding didn't, and that was perhaps an issue. I wonder if you raised that with anybody, and whether you think actually an increase in funding would have helped at that time.
I think in the instance of the pandemic, I don't think that the funding was really the primary issue or cause. It was lack of bodies, essentially. So I think that where there was increased expectation on midwives to arguably extend or expand their role slightly or take on work that would have ordinarily been done by another health professional, there was arguably an anxiety around, are they the right person with the right skill set? But actually it was the additional resource, and the resource pressures did not arise from funding. They arose from, actually, we do not have enough midwives. It wasn't about the ability to employ them or, fund them. It was primarily that they didn't exist.
And I will return, of course, to the role I think that midwives took on that perhaps they weren't taking on before the pandemic. But I want to take you out of turn in your statement, because you discuss at paragraph 52 a survey which you conducted. And that you explained that in autumn of 2021, the organisation carried out a survey of its members. And that survey, you say, wasn't directly about the pandemic, but because of the timing of it, you certainly are of the view that the responses are quite reflective of the membership's experience of the pandemic. Is that right?
Yeah, absolutely.
And at paragraph 53, you say the response to that survey was overwhelming. Yes. 4 out of 10 members responded.
Yeah, higher than we've ever had before.
And I think you also say that there's an option in the survey to, instead of just give a short response, they had the ability to write prose, to write text about experiences, and you gleaned a lot from that as well.
Yeah, so a significant number of the respondents elected to provide a narrative to expand on their primary answer to the questions that they were asked. And I think in our analysis of what would have originally been intended to have been a survey where we could, collate data essentially, that would be particularly numbers focused, actually turned into a thematic analysis of themes, because we had such a high level of narrative response within it, that we could not fail to explore that and understand it. And we then acknowledge in the writing up of the report of Scotland that actually it's very apparent that one of the heavily influencing factors in the narrative responses was their experience of working during the pandemic. So although we never specifically asked about that, that was what was volunteered in the responses.
Thank you, and I asked you about that because I want to come back to some of the answers where they're relevant in terms of what you're talking about. But going back to paragraph 21 of your statement, you say there was a focus on reducing care which was provided within the hospital setting.
Yes.
And that meant that more care and more maternity care was provided in the community.
Yes.
What impact do you think that had on the membership?
I'd say it was significant in the sense, well, the different areas. There's the impact on the community workers, who, of course, like all of healthcare staff, were working with depleted numbers. There was no additional resource, and by resource I mean staffing resource, to support the movement of staff from other areas into community to go with the work, if you like, because actually there was still a pre-existing workload in other areas. And what I think the biggest anxiety that came across from our community members would have been that they were, where they go to work, be it a clinic or a patient's home, that is their workplace. But these were much more uncontrolled environments for them. So in actual fact, the guidance that was out there around, protecting yourself, protecting patients, protecting staff, minimalising contact and interaction was hugely, hugely difficult to apply in practice when you were repeatedly going into uncontrolled environments, where there may not have been adequate ventilation, adequate hand washing facilities. You weren't in control of how many persons were present in a patient's home, for example, and that created significant anxiety. You add on to that the nature of the work they were being asked to undertake would have been essentially some tasks that patients would have previously come into an acute setting to have undertaken, and where possible in any way there was a shift to try and undertake aspects of care in these environments. So it was about, we want to prevent patients and women and families from coming into a healthcare setting, because that's, you know, about avoiding the contact, the social distancing, etc. But the challenge then was, are we still providing the same level and quality and safety of care in a community setting as we would have done in an acute setting? Are the individuals providing it, you know, of the right skill? Do they have the right tools to do so? And is it to the same standard, essentially? And do they have the time and resource to do it? So these were the competing kind of priorities and pressures.
You, I think, deal particularly with the topic of community-based care at paragraph 33, and you give an example of some of your membership requiring to provide home birth services.
Yes.
And those persons particularly being pressured, I suppose, because that is an environment which they have absolutely no control over, but with which they of course are required to work in.
Yeah. So it's women have choice of place of birth, and we obviously want to promote that they have that option to elect to have their baby in the safest, most appropriate setting for them with the freedom of choice. And so there's always a number of women that will request and elect to have a home birth. One of the challenges was that was thought to increase as a consequence of the pandemic, because obviously there was awareness that we were trying to, as far as possible, not bring women and families into hospitals, but also their own anxieties, arguably, about potentially coming into a hospital environment during such a period, arguably had an impact on their decision around place of birth. So there were increased pressures to provide intrapartum care in these settings, but there was also a period whereby we struggled then to understand whether it was actually safe to do that, from that perspective of providing healthcare, the risk to our staff versus, you know, the benefits to our pregnant women, and also did we have the resource to continue offering that choice as well. So there was some real competing priorities there that created a lot of stress and anxiety across the workforce, and arguably for women as well.
Can I ask a question rising out of the last two answers you've given, Ms. Currer? You used in the previous answer the word acute twice.
Yeah.
My knowledge may be incomplete here, but acute at least suggests that in non-pandemic situations, those persons would have, and indeed it would have been in the best interests of those patients, those women, to have been treated in hospital. Is my understanding correct?
Yeah, so in generalist terms, my use of the term acute would be hospital-based care. And so what I am describing is where care that would ordinarily be provided in a hospital setting as being the best place for that care to be given was then shifted to a community context. And
whilst, and I'm certainly not criticising anyone in relation to this, but when those difficult decisions were made, then the inference must be that the patient was being placed in a suboptimal position or a suboptimal place because they would routinely have been taken into hospital, but the pandemic required them or made it necessary for them to be treated at home.
I think in any of these situations there would have been a degree of risk assessment as to, you know, where on the scale of risk would it sit to provide this care in a different setting, and what would be required to mitigate that risk. And so I wouldn't, you know, I'm not suggesting that everything was just suddenly dumped into a community setting, because arguably that's not possible. But what I would have said was that where possible, certain aspects of care were selected as being something that could arguably be amended to an extent to still provide that care albeit in a different way.
No, I understand that completely, but yeah, thank you.
Thank you, my Lord. Turning back to paragraph 22, I think you explore there that an issue amongst the membership was that some staff were redeployed to work in clinical areas which were unfamiliar to them and they hadn't worked in some time, and with staff and a team that they didn't know. Are you able to tell us what issues members reported as a result of that decision being taken?
So something that evolved quite quickly during the initial phases of the pandemic was a process that is now becoming embedded as a real-time staffing assessment. So what each of the clinical areas were tasked with undertaking at the start and arguably during some shifts was, you know, what is the demand for care and what is the staffing resource, and then making an assessment across the wider area as to where was the imbalances were in that and how they could mitigate some of the risks where there was potentially not adequate resource by the movement of staff. And what we certainly gleaned from our survey thereafter was that our respondents reported that on a regular basis they were being moved, so they were reporting to work to their ordinary place of work, and either at the start or during the course of their time at work they were being asked to go and work in a different ward, different clinical area, and sometimes on a different site to support the level of work or the risk that was perceived elsewhere. That's highly stressful because they are used to working in a particular aspect of their role. When you go to a different ward, even just simple things like, you know, where are things kept, what are the policies and procedures, what is the skill set of the people I'm working with? I don't know the people I'm working with, I'm not familiar with them, I'm not familiar necessarily with how patient care is delivered here or the policies and protocols that are in place here. So that automatically becomes a more stressful scenario. And obviously doing it when you're going to somewhere unexpectedly that you're not familiar with is stressful in itself, but to do it because you're responding to a high pressure, the expectation and the anxiety is even further escalated, and that happened regularly.
You say within that context there was a high demand for upskill, and I wondered what you meant by that.
Upskill is potentially too generalist a term. It wouldn't be a skill that would be beyond the expectation of a midwife, but at any given time, maternity care isn't streamlined in such a way that you will apply all aspects of your skill set, you know, every day. So you will often, for example, community midwives are familiar with providing community-based care in the context of how they do that. Midwives working in a labour ward are much more familiar and up to speed on providing intrapartum care. So if I was to suggest that a midwife from a labour ward had been asked to go out and work in a community setting that day, she would be particularly unfamiliar with potentially antenatal care pathways, protocols. So it wouldn't be that she didn't have an awareness of them. It would just be more in practice, the familiarity of that skill isn't there, and that's where it would be, I have to understand and gain a level of kind of knowledge and insight quickly here. So it wasn't that the skills, the core skills didn't exist, it's more the familiarity of them in practice that would have been the challenge.
And can I take it from what you're saying that, again, without criticising anybody in particular, that necessarily has an impact on the care that's provided?
I think, you could say in any scenario that if somebody lacks confidence or feels anxious about how familiar they are with what they're being asked to do, then that arguably presents risk in terms of how that's managed then, and their ability to access support to manage that sense of feeling a little bit out of their depth potentially, and I think in an ordinary scenario, you would go to work in a supportive environment. You would say, oh, I've not worked here for a while. You know, can somebody show me how to do things? How does this work? But in the scenario of the pandemic, that support wasn't there. So that exacerbated that anxiety more. You could argue then that that presented risk. And our members did report, particularly in the narrative, that they felt vulnerable.
Talking about taking up different roles, you go on to talk about, rather than a kind of clinical, a different clinical role, you talk about midwives also there being a sense that they're taking up the role of two professions, GPs and social workers, because as professions they were generally seeing less people face to face, and midwives by necessity were. Did you get a sense that the members felt able to take on those roles, or was that a significant additional pressure?
Do you mean able in the context of having the resource to do it or having the skill to do it?
Both.
So I think that, you know, we won't be unfamiliar with the fact that unless it was deemed absolutely essential, GP contact was exceptionally limited. And many women in pregnancy are healthy, but they have healthcare needs associated with their pregnancy. Many have additional needs arising from other pre-existing medical conditions or conditions that arise as a consequence of their pregnancy. And others will have other healthcare needs that are not pregnancy related that coincide with their pregnancy. So what we saw from that perspective is that where they were perceiving barriers to accessing healthcare from other appropriate healthcare professionals for the needs that they have, they could access healthcare via the maternity service. So there was an increased number, there always is a number of women that will present in maternity services with a non-maternity specific need, but that was significantly increased during the pandemic, where, you know, if a woman was experiencing, you know, a problem that wouldn't have been deemed to be maternity or obstetric related, she would present to the maternity services as a route in. And obviously the anxiety of the pregnant population, like the whole population, was high in respect of, you know, where do I access the appropriate healthcare, and how do I do that without facing perceived barriers. I think our members also reported that you know, other elements of care still existed. So lots of maternity care relates to social need. There's also a level of, obviously, assessment from a child protection perspective, where ordinarily midwives would work in collaboration with social services and health visiting colleagues to do that multi-professional assessment and oversight and care planning. But because they were the individuals that were having the most direct contact, because they didn't have an option not to with pregnant women, they felt a little bit more of a lone voice in some of that work because the engagement from other health professionals was more detached.
And
so the burden felt heavier.
I was going to ask, was there a feeling that essentially they were having to take on a child protection or a safeguarding role where ordinarily that would be a duty and a burden on another profession?
It would ordinarily have been combined assessment and decision making, and there was a sense that they were then being given a lead role to some extent in that, and that obviously created an anxiety there.
You go on to talk about the guidance and messaging that was received, and I think you've already said, I think, that guidance and messaging wasn't necessarily tailored to maternity and obstetric care, but really was more generalised, and you produced guidance which was more specific.
Yeah.
You say at paragraph 24 that the guidance lacked clarity, and you give a specific example at paragraph 25 involving resuscitation of a newborn baby.
Yeah.
I wondered if you could explain that, and perhaps it might help to give us a good example of where the messaging wasn't perhaps as clear as it could have been.
I think the issue around the messaging was its generalisation, and when that and the frequency of change. But if we took, you know, one message in isolation. What you would find would be how that was then interpreted to different clinical settings varied. So I, can recall specific incidences of midwives contacting us saying, we are all expecting to be fitted for FFP3 masks because our role involves us actively resuscitating newborns, neonates. However, some of the management or some of our leads within the organisation are telling us that newborn resuscitation doesn't require an FFP3 mask. But that's not how we read the guidance. So there was this conflict then around what they understood to be the best approach to providing care to protect everyone concerned, and how others potentially then translated that, and there became a conflict around what you should and shouldn't be doing. And I specifically recall a few members saying, if I'm not going to get measured and fitted for FFP3 and be allowed to use it, I can't go to work. I'm not resuscitating babies because of their anxiety around the risk.
I think later on in your statement you discuss FFP3 masks, and I think you report that there to be a feeling that those were hard to come by and were rationed for a period.
Yes. Yeah, I think during that particular kind of period around, the issuing of masks and where they should and shouldn't be used and what categories and types should be used, it was felt by our members that some of the interpretation of guidance was arguably being steered by the availability of the resource as opposed to the best approach clinically. So they were perceiving that there was this conflict between what we should be doing for safety and what realistically we can do because of supply.
You go on at paragraph 26 and 27 to tell us about the experiences that members reported from communication with those who are accessing maternity care. And you say, and you've already said, that women and families experienced increased anxiety and vulnerability. Mm-hmm. You talk us through the reasons for that, which I think everybody would understand, that they weren't able to access social support, they weren't able to bring support or have mm-hmm. visitors in to the hospitals. And you say that this led to increased hostility by those accessing care to staff and to members that you heard from. Can you tell me more about that hostility and that conflict because perhaps of rules and guidance that were in place?
Yeah, I think what we heard, particularly on a ward basis, was our members felt the immense frustration and stress and anxiety through them having to facilitate the restrictions. So they didn't make up, they weren't the decision makers in that, but they had to comply with that. Therefore, they were the point of contact with the public as being seen to be the enforcers. So the frustration and the anxiety and the stress felt by women and families, and their extended families, arguably in some cases, was vented directly towards our members at times. And that was distressing because they were enforcing something that they could see was arguably had detrimental impact. It was being done, it was the conflict between it was being done for the right reasons from a kind of physical safety perspective, but there is a secondary consequence here, and that's really hard because we are denying these people the support and the access to each other at quite critical, unique times in their lives. And so a real conflict there between doing the right thing for the right reasons, but being aware of the consequences for them not being great. And I think they definitely experienced the frustrations felt through women and families of the impact for them.
You say that perhaps all of these impacts were acutely felt by student midwives. And you go on to talk about paragraph 39, there being a number of reasons why student midwives were very significantly impacted by COVID, by the pandemic time, and that has perhaps now had a long-standing impact. First of all, can you tell us the concerns and the experiences that student midwives experienced because of the pandemic?
So to put it into context, the midwifery training is typically a three-year programme, a three-year degree programme. But unlike in any other degree, nursing and midwifery degrees are heavily reliant on a significant clinical component of clinical learning and teaching and assessment. So there is a requirement that they have to do a number of clinical practice hours, they have to be exposed to a number of different types of clinical scenarios, they have to be taught, they have to be assessed, they have to pass that, and they have to do certain levels. Like all of the population, our student population were also subject to recommendations around shielding. They also obviously had issues in relation to caring responsibilities, and what they experienced going into their clinical placements was a workforce that was unable to fully support their clinical learning in the way it previously would have done. Also, because of social distancing, even in healthcare settings, and changes to how care was provided, they weren't then getting the same exposure to clinical experiences even when they were on placements. So that all delayed and deferred their ability to acquire that exposure and that learning. We had many during that period that had to extend their training period to make up time. But what we were already working with was quite a pressurised number of student midwives, because we had the highest number in training than we'd seen previously to try and meet future workforce projections. But when we increased the numbers of students, we didn't in turn increase the number of midwives. So there was already a significant number of students being supported in clinical practice. If you then have gaps or inabilities to do that, and that's deferred down the line, that doesn't mean that you can defer the others coming through the system. So what that created was this backing up, if you like, of student needs that was still being put upon a workforce that wasn't fully able to deliver all aspects of clinical care in the way it should ordinarily have been. And of course, the experiences and the teaching of students would have become further down the priority of providing safe clinical care to women. So the knock-on effect would have been that they weren't supported in the same way to learn, their learning took much longer, and that created delays then in the outputs at the other end of midwives qualifying and being able to enter into the workforce to support the workforce gaps that then existed. So it was this kind of multifactorial impact, really, that there was the immediate impact, and then there was the longer term impact of that.
And turning back to the survey that you mentioned later on in your statement, one of the interesting statistics that I read at paragraph 37 was that of the respondents to the survey, 12% of them qualified less than 2 years ago. So in 2021, that would have been 2019 or less than that period, and 51% of those who had been qualified for less than 2 years said they had been left in charge during that period.
Yes. So one of the reasons that we did the survey, and we did a survey in a way that we had never done before, was because we were very, very aware of the sense of extreme burnout across our membership. And what was being reported back to us, either directly from individuals or through our networks and branches, was that one of the biggest stresses being felt was newly qualified midwives working without support of more experienced staff and frequently being left in charge when they would previously have worked on a shift you know, where they would have been supported by more experienced and senior members, they were sometimes turning up to work where the whole shift were arguably newly qualified, and there might have been some bank workers that weren't part of the core team, and so they were deemed to be the individual that was most experienced in that scenario, so had to take charge. And that's not something that would ever have happened. Of course, what you would do with somebody in their period of preceptorship post-qualification is you would begin to expose them to some of the leadership elements of their role as a practicing midwife, but that would be undertaken with support. But what it felt like, or what was being reported, was that it wasn't done in that way, and it just was an expected norm, and that they felt very isolated and vulnerable.
At paragraph 44 of your statement, you say quite starkly, I think, that maternity care should have been prioritised as an essential service during the pandemic. However, this wasn't always the case. My first question is, it might be obvious, but why do you say that maternity care should have been prioritised?
You can't defer a pregnancy, and you can't, you know, say to people, don't become pregnant. So I think obviously what we saw in healthcare immediately is anything deemed to be an elective, non-urgent procedure was postponed or deferred in order to be able to respond to the increased demand for immediate high-risk acute care. What perhaps went unrecognised was that, yes, lots of pregnant women are well, but every pregnant woman requires maternity care to ensure that she has a safe and healthy pregnancy and outcome. Some of them will require enhanced levels of care, but all of them require care at specific times. From a safety perspective, we can't defer that because there are risks with deferring it. So I think what we felt was unrecognised was that we can't, deferring, you know, a week, but an episode of care by a week isn't possible. You can't defer postnatal care. You know, it's acutely kind of required. You can't prevent women from being in labour when, you know, when they're, these are things that we do not control. And so those numbers remained unchanged for us. There was no shift in, or any ability, essentially, to shift on the demands of maternity services or defer any of it in any way. And yet, there was resource taken, sometimes to support other areas of service. That could be that some midwives on a shift by shift or on a more kind of planned basis were asked to support other areas of healthcare, but that some of the maternity settings were used by other areas of healthcare to provide care for other patients. So we are very familiar with, you know, a bay on a ward, for example, which would have been for postnatal care, may have been handed over to the acute side to provide beds to respond to the pandemic, medical beds.
Perhaps the clue, Ms. Currer, is in the first line of paragraph 44, if you take out the word prioritised, because maternity care is, if ever there was one, an essential service.
Yeah, it's a universal service as well. It's not something that we can be selective of. Every pregnant woman requires maternity care.
Yeah. And women are always going to have babies if the human race is going to survive or go on. Yeah, sounds trite, but it's true.
I think picking up on that issue about the approach taken to maternity care, at paragraph 63 you say, and we've touched on it already, but a lot of the guidance was written in such a way that it was ambiguous but aimed at acute hospital-based care. And that wasn't helpful for the nature of your work and the work of your members.
Pat, which number?
It's 63, sorry, it's just there. So
okay.
I think you say guidance was written in such a way that it was often ambiguous but aimed at acute hospital-based care, wasn't helpful for the nature of our work when members were being asked to provide care which would ordinarily have been provided in a hospital but in a home or community setting, and the guidance didn't translate to that.
No, it didn't. So if I was to give you one example, and it was a document that the Royal College of Midwives wrote, but actually I led on writing it, was about visiting in a maternity setting. So what I had done with that is had to take the guidance produced by Scottish Government and essentially translate that into a maternity setting. So a lot of the visiting rules and restrictions, if you like, were done on the assumption that, you know, we were working with well functional adults that were ill and in hospital. And what perhaps wasn't understood was that when women are inpatients in hospital, it's not really just the women that's the patient. You know, we very much see women and their partners and families. It's yes, they primarily need the physical care, but the care is actually family care, and it's really a big part of what we aim to promote and encourage is the inclusion of partners in the wider family and supporting that transition to parenthood. And so to not, and that is essentially how our services work, that it's fully expected in a maternity ward that we have open visiting. You know, we have a policy where partners can stay overnight. So it's not the same as most acute healthcare settings in that context. So it did really feel like there is, you know, the way the guidance was written didn't really take into account actually that meant something quite different for our maternity settings. How were we going to translate this over about, you know, the restrictions on who visited you, how long they visited you for, the process, you know, if they'd been exposed to COVID, the testing, you know. We were having to say to some women who've just had a baby, their partner, because of the guidelines, can't be with them during labour and may not be with them for the first few days of their baby's life. That is very, very difficult to do. And so we had to be really, really clear that we were telling our members, you know, the right interpretation of the guidance, because it was so stressful for them to implement something like that. So, yeah, so that a lot of one of the guidance documents we wrote was very much about having to manage that generic guidance in a maternity setting, but to make it as possible as it could be to still enable women and families to have contact.
I suppose
now,
that...
Ms. Traynor, you're into your last 10 minutes, or roughly your last
I'm
10
grateful,
minutes.
my Lord, thank you. I think that in itself, so the restrictions perhaps generally on visitors to hospitals, is an example of where you say at paragraph 66, I don't think the government fully recognised or understood the unique nature of maternity care. My opinion is that the guidance didn't acknowledge this and the associated medical well-being needs of women and families.
Yeah, the mental well-being needs of women and families, yeah. So a huge component of maternity care is around the transition, that, you know, it's a significant life event and it's a family event as well. And a huge part of the role of the midwife is very much a public health role, in as much as delivering on physical, clinical care needs. There's lots about the social transition to parenting, the future family, and the support networks and needs around that. And so that detachment and that change and shift in care, bearing in mind these women and families were also being isolated from their ordinary support networks in life, was significantly increased in terms of the isolation and detachment, and our ability as professionals to still undertake those aspects of care when we were being very selective and restrictive on what care we provided and how and where we provided it.
Turning to the effect that care and the quality of that care has had on staff and on members wanting to continue into the profession, you say, going back to the survey at paragraph 56, that quite starkly 75% of respondents as of autumn 2021 had considered leaving their current post due to staffing levels, dissatisfaction with the quality of care they were able to provide, and dissatisfaction with the level of support that they were receiving.
Yes.
That would seem to me 75% to be quite a stark figure, and effectively 3/4 of the profession are not satisfied with where they're at.
Yeah, so I think in the narrative, a thematic analysis element of what is in the report and the survey, we state that we believe our profession is at breaking point based on the respondents in the survey. Half of those respondents also said that they said there was rarely safe staffing. They reported being unable to support students adequately in newly qualified midwives, significantly reduced skill mix. 9 out of 10 reported working without breaks. 50% of that figure said that was happening regularly, 2 to 3 times a week. And the figure that 75% were considering leaving was arguably heavily influenced by their experience during the pandemic. However, we undertook a snap poll of our members across the UK during the week of the 4th of March for 7 days, and we asked some short, succinct questions in relation to: are you working hours beyond what you're paid or contracted to? Do you believe you're working in a safe setting, etc.? And during that, in Scotland, the figure that said that they had considered leaving in the last 12 months was 68%. So what that tells us is that this is not a profession that has really recovered in the context of the impact of the impact of the pandemic, and the consequentials of that is still very much being felt and is very much unaddressed.
You're somebody who's been in your role for 15 years.
Yeah.
And can I take it from that the fact that you've put these statistics within your statement, you attribute them at least in part, if not largely, to the pandemic?
Yeah, what I would say is I would never have imagined that in midwifery we would have had such a staffing crisis in Scotland. Historically, we were always felt to fare better than the rest of the UK, and maternity care in Scotland is world renowned, in many ways. And what we are seeing now, we did anticipate, because we do workforce projections, we did anticipate that there was going to be a dilution of experienced staff, because we can look at the age profile of our membership and we can see that. So in the absence of being able to predict a pandemic, we did predict that there would have been a shift in skills set and that there would have been a higher turnover at certain periods in time. Hence, I made reference earlier to the fact that we had higher numbers than ever of students, because we were obviously trying to mitigate that going forward, and that's part of the work that we would have done every year with the government. What is the future need? What are the figures telling us? We would have lobbied for a number, and that arguably was all on track to deliver us, that to safely kind of transition through a wee bit of dilution of skill mix and having those increased numbers there coming out of their training to continue to safely staff our services. We didn't obviously anticipate a pandemic. We also didn't anticipate how our profession felt about some maternity policy and strategy that was implemented pre-pandemic as well, and I think there was a combined effect there. But the pandemic did arguably accelerate the loss of experienced staff, and we have not been able to put through the same numbers of qualified midwives for all of the reasons that we've previously discussed. And also the impact has meant that people are potentially going to be leaving a profession that we ordinarily wouldn't have had them leave. And we haven't planned for that, because we didn't know that would be their experience and how they felt.
I think you say earlier on in your statement that anecdotally there are a number of members who have left, retired early when they weren't planning to, just because of the pressures that they felt during the pandemic.
Yeah, retired early and potentially moved into other areas of healthcare that potentially felt less immediately pressured, or they might have felt were better for them from a kind of work-life balance perspective. Yes.
I'm conscious of the time, and I wanted to take you to the end of your statement where you offer some reflections for us about what you hope for the lessons to be learned and the hope for this inquiry. And at the very last paragraph, paragraph 73, you say your hope for this inquiry is not to apportion blame, but to look at how we can learn. And you pose a question there to say, what have we learned about our health services? And I wondered if perhaps I could quite cheekily ask that question to you, but specifically in relation to maternity care. What have we learned about maternity care from the pandemic?
I think what we need to learn from it is that maternity care is a universal service, but by not getting it right and providing safe quality care, we're missing an opportunity to really set the seeds and foundations for future positive health for women and families. So it's a really opportunistic time, because you're potentially engaging with people that haven't previously engaged in healthcare. And there's also a massive public health element to it. They leave maternity services, they go into health visiting services beyond that, and other aspects of healthcare. And if we optimise maternity care, and there's lots of research evidence to support that we can transform the long-term healthcare of our population. So to deny women safe quality healthcare would be really remiss in terms of future population health. In terms of the immediate impact of that, I think what we have learned is that there's a massive mental health aspect to maternity care as well. And if women lack that social support or that wider sense of support and contact, there is an adverse consequence in terms of their mental health and well-being. And from a maternity or midwifery perspective, is that midwives are important, and they have a vital role in all of this, that we invest appropriately there to ensure that we are not failing our women and future families at the first hurdle, really, and giving them a negative experience or an experience that presents risk, or in some cases can cause trauma, as opposed to prevent it. So I think it is definitely something to take away. What we learned about the health service, and particularly my concern is obviously around maternity care, is that it was already on the brink. It didn't take much to reach that tipping point. It really didn't, because we were running a service on the goodwill of midwives. We are still running a service on the goodwill of midwives. I think we need more recognition of the fact that had it not been, and continue to be, for the dedication of health professionals to the role that they undertake, that we wouldn't still be providing largely safe care, but that's not as a consequence of having a really well supported and invested maternity service. We have that because we have dedicated professionals that go above and beyond every day to make sure that women are safe.
Thank you very much. I don't have any more questions for you, but is there anything very briefly that we haven't covered which you think is important to raise?
I don't think so. Thank you
for your time.
Yes, thank you very much indeed, Ms. Currer. You're doing the next witness, I think?
I am, yes, my lord.
Rena? Very good. 12:10?
Yes.
Good. 12:10 then. Thank you all. Now, good afternoon, Ms Trainer.
Good afternoon, my lord.
Ready to go?
Yes, and the next witness we have is Jackson Cullinane.
Good. Good afternoon, Mr Cullinane.
Hello there.
Mr Cullinane, I wonder, could you tell us your full name?
John Jackson Cullinane, or Cullinane as some people pronounce it.
Cullinane, apologies, Cullinane. And you indicate within your statement to us that you are a full-time official at Unite.
That's correct.
You have provided a statement to the inquiry, and for our benefit, that statement bears the reference SCI WT 0174, 5 zeros and then a number 1. And all of that information that you have given us will form part of the evidence to the inquiry. Okay. Now, you've got that statement, I think, in front of you. It will appear on the screen. But if you've got any problems in reading that, or you want to take time to read it, then please just let me know.
Okay.
You tell us, firstly, at paragraph number 3, I think, that you've been employed by Unite directly now for over 23 years.
That's correct.
In that role, you go on to tell us about the position of Unite in Scotland, and some facts that you give us are that it represents 1.4 million people in the UK and around 150,000 in Scotland.
That's an estimation. The membership figures will vary from month to month because people join, people leave for various reasons.
And you then go on to say that Unite represents workers from virtually every sector of the economy.
Yes.
In terms of your current role, I wonder if you could tell us, first of all, the responsibilities that you have and how you go about fulfilling those.
Right. My current responsibilities as the head of, it's a big long title, the head of Unite Scotland's Campaigns, Politics, Research and Communications Unit. And effectively what that means is that I have a direct team who deal with research, who deal with our media, including internal communications and social media as well as external. And we deal with surveys of members, ballots of members, including all of the non-statutory industrial action ballots. So it's quite common, for example, before moving to a statutory ballot, to have a consultative ballot of members to see how they feel about a particular issue. And we deal with the politics and policy. So in terms of policy, we'll organise the union's policy-making conferences. We'll oversee the procedures of that. Of those, we'll deal with our input into some of the external conferences that we are affiliated to, so the likes of last week's S2C Congress. We would be involved in writing speeches, looking at the content and motions prior to the Congress, etc., taking the delegation meeting at that Congress. We have our own Scottish policy-making conference, and we deal on a day-to-day basis with liaison with politicians, talking to officers and advising officers about if there's a political angle to some of the industrial issues which they may encounter. So that's a very brief overview, but it's I mean, I've held this role now for a few years, but prior to that role, I started off, you know, as an education officer, basically training union reps. I had been a full-time lay union rep myself for many years. And also then becoming what we call an industrial officer. So I represented workers directly in a whole range of different sectors, negotiated wage claims, took you know, appeals and grievances, including in local government, and was the Deputy Regional Secretary at one point of the former Transport and General Workers Union, which became part of Unite. So that's the current role and a bit of the background as well.
We've heard, I think, from another witness about Unite having particular sectors. I wondered, from what you say there, can I presume that your role really transcends all of those sectors and is more high level?
Yes, yes, it is multi-sector. And indeed, when I was an industrial officer, negotiating wages and representing workers at the workplace, that could also be a multi-sector role. Having said that, in terms of the sheer workload, it didn't cover all of the sectors at any one time, so you would have an allocation of work. So I might have had, for example, road transport, buses, local authorities, chemicals, and then a few months later, I might have some other sectors, to deal with. But the current role is multi-sector. It covers the entire sectorial spread of the union's membership.
And I take it from all of the activities that you've described, that perhaps leads you to have quite a good overview as to some of the issues that were affecting members during the pandemic.
Absolutely, and where I had a particularly good overview was that at the point of the pandemic, I was also the president of the STUC, which was an elected position which you generally hold for 1 year, but because of the pandemic, my tenure was a bit longer, because to get the re-election of the president or the new president, it takes, under the rules, it requires a Congress, and they didn't physically have a physical Congress. But by virtue of that role, I served on the STUC's COVID-19 response group, which was really the body which discussed throughout the pandemic regularly, certainly on a weekly basis, sometimes, a couple of occasions during the week, discussed the situation with representatives of the Scottish Government. Generally, these COVID response group meetings were led by the appropriate government minister. So I had a really good insight into what was happening at that point.
You were asked, as part of your statement, I think, questions particularly relating to the health and social care sector. And you tell us at paragraph 5 that health and social care workers are quite difficult to provide a figure for because they're effectively across different sectors, the NHS, local authorities, private sector, and voluntary and third sectors. And so you're requiring all of those people to accurately reflect what the jobs of the people that they employ are.
That's correct, and I think you'll see for other sections of the statement and some of the things that may come out in our discussion this morning, that some of the experiences can also vary between the different sectors. So just to give you an example, I mean, I think I make some reference to the situation of pay and how that impacted, on people throughout the pandemic and indeed beyond. And the reality is that social care workers in the health sector and in the local government sector are governed by centrally bargained terms and conditions and pay rates, whereas those in the voluntary sector or third sector and those in the private sector are currently not. And so their experiences differ depending on what sector of social care they are employed in.
Just briefly, you touch on the figures of all of those people, and as you said, it's difficult to provide a figure, but you would estimate around 16,000 to 17,000 in Scotland of health and social care work.
That's probably an underestimation, actually.
Turning to those pay issues and some of the condition issues that you raise, you go on to discuss a number of them within your statement. And the first issue I wanted to ask you about was furlough pay, and that's at paragraph 17. You say that to you, furlough pay was raised as you found that many members were having to argue to get put on furlough because there were many employers who weren't willing to do that, to put their staff on furlough. I wondered if you could explain to us a little bit more about that issue and how it came about and whether it was resolved.
Well, I think this is an example of what I kind of alluded to earlier, where the experience of social care workers may differ depending on what sector of social care they are in. Those who were employed in the NHS and those who were employed in the local government sector tended to have less of an issue in terms of accessing furlough. And when we're talking here, of course, about health and social care workers, bear in mind that those who would be looking for furlough would be those who were in roles that it wasn't absolutely crucial for them to be at the workplace. So the majority of them would be at the workplace. But there were other people who were doing administrative roles or whose direct patient or person contact may have been on a temporary or a periodic basis, who could, where it wasn't necessary for them to be at the workplace. And those people would be looking to get pay protection and furlough. What I mean by pay protection, by the way, is that our position as a union was always to go for pay protection and have people on full pay if possible, rather than them having to go on furlough where it's 80% stuff. But those who were working in local government, those who were working in NHS, generally were able to get access to full pay or to furlough. People who worked in the third sector or in the private sector, a lot of them found it more difficult to get that. This, I think, links in to a degree to some of the other comments I make about, if I just above it, about at the start of the pandemic, the confusion about what essential work was. There was a lot of employers, not just in the health and social care sector, I have to say, who interpreted this as being, if you're in a sector, then you are, that is deemed to be essential, then you are an essential work. Whereas what they should have done, and what the Scottish Government eventually reinforced, was that you were talking about the task being performed rather than the sector. So there was a lot of people in the third sector and the employers in the third sector and in the private sector of social care who just interpreted it as meaning, well, you're a social care worker, therefore you're an essential worker, therefore you need to attend the workplace, therefore you don't qualify for furlough. When in reality there were some people who might have been doing administrative roles or whose person contact may have been on a mere periodic basis, who were properly, in our view, entitled to either full pay protection or furlough. And when they made that approach to their employers, they were being denied that access. It did quieten down and smooth over quite significantly once there was more clarification as to what was meant by essential work. And also, one of the kind of breakthrough for us periods where the Scottish Government issued a guidance which basically said that people shouldn't suffer any detriment by virtue of COVID situation, either in terms of pay or in terms of discipline if they had COVID and couldn't turn up to their work. So all of that helped in terms of resolving that. But initially there were some employers, particularly in the private and third sectors, who were resistant to giving people furlough who could have been furloughed at that point.
You mentioned that distinction in relation to the third and private sector, also in relation to sick pay.
Yes. By virtue, probably because of the lack of collective bargaining coverage in terms of it being in the same level as what it is in local government and in NHS, there are some employees in the private and third sectors who had no contractual access to sick pay over and above the statutory sick pay minimum level. So that comment is really just highlighting that people weren't able to access sick pay. That was a major issue in terms of adhering to what was required in order to combat the spread of COVID, principally and particularly in the initial periods. The emphasis before we had vaccines and all the rest of it, the emphasis was very much on lockdown, minimise people, having contact, out in society and at the workplace and with other people. But workers in social care who didn't have access to sick pay, if they contracted COVID, were then left in an invidious situation whereby they couldn't physically go to the workplace, but it meant that they were in poverty by virtue of that. And I think I come back on to, and I will come back on to, if I can at some point, about this being part and parcel of the lessons to be learned, and indeed the preparedness, in terms of, touch wood, it never happens, but in case we have another similar pandemic, we said throughout the COVID pandemic that pay is a public health issue, and that's what we meant by that. If you want to ensure that there's no spread of COVID, and you want to minimise the spread of COVID, you need to remove that barrier whereby people feel that unless they go out, then they're not going to have any kind of income. And that's why we've been pushing quite hard on bringing in what we call sectorial bargaining. So we have centralised collective bargaining in local government. We have centralised collective bargaining in the NHS. We don't have it in the third sector. So we have, where unions are recognised in the third sector, it's individual bargaining with the individual employers, and similarly in the private sector. So what we think needs to happen is that the third sector, the voluntary sector, and the private sector need to have some form of collective bargaining, and when that's established, ideally we would then look for sectorial bargaining across the entire social care sector. That has other benefits in terms of preventing undercutting and people being on the same minimum wage rates and whatever. But from the point of view of public health and pandemic preparedness, then it's about tackling that pay issue, which does impact, in our view, on public health.
And talking about that pay as a public health issue, you go on at paragraph 20 to say, I think, something you've already touched on, in that really what effectively helped that situation was the no detriment guidance which was given by the Scottish Government, and it was when that was issued that people finally listened and actually said, yes, okay, we'll pay sick pay to the workers who are not able to come.
Yes, it didn't all listen, it has to be said. This is a wee bit about the guidance rather than legally enforceable stuff. But it was a major positive leverage, particularly in the health and social care sector, for employers to do what we were asking them to do. One comment I would make about it is that, obviously it's a big plus, and we welcome the fact the Scottish Government did this. Where there's a bit of a negative, I think, is towards the end of the pandemic, where I think they actually removed this too soon in terms of the Scottish Government saying, well, that guidance is now gone. Because we continued to have cases of COVID. Maybe not on the same, certainly not on the same scale as we had at the height of the pandemic. And indeed, we still to this day, have people who require to be absent from work because they're ill by virtue of having COVID. And in our view, that guidance and general principle should have remained in place in order that people who have to stay away from the workplace through no fault of their own don't suffer a detriment, either in pay or in terms of the applications of absence control and discipline procedures. And it's relevant, particularly relevant today in terms of long COVID cases, where we are experiencing and continue to experience a lot of employers who are dealing in inverted commas with this issue by seeking to get down the capability route and to say, well, if you're going to have this, long-term situation, which is always, for the foreseeable future going to present a difficulty for us, then, we question whether you're capable to continue to be in employment, and let's look for an exit. And that's sometimes the kind of first port of call for some employers. And I'm not just talking about health and social care here, I'm talking about, you know, other employers in other sectors. So for us, I think that that basic principle should have remained in place, and the Scottish Government shouldn't have basically indicated that it was now over.
You go on to, I think you mentioned that very much later on in your statement at paragraph 68. As you've said, your view is the Scottish Government removed the no detriment guidance too quickly as we were coming out of the pandemic. You then go on to say in that same paragraph, in fact, our position as a union is that COVID should be regarded as an industrial disease.
Yes, I mean, I may come on to some of the stuff that we mentioned about, I mean, I've quoted for the TUC report about REDOR and the reporting of workplace
Don't worry, we will
transmitted.
go on to mention
Right.
that, yes.
But there's a real tendency for employers to suggest that COVID is a community transmitted disease. It is a community transmitted disease, but that it's a community disease which isn't transmitted at the workplace. It's not a workplace disease. The reality is that, you know, there are literally thousands of workers who contracted COVID at the workplace. We know that, right? We can see it. You know, we see it in, you know, food processing, you know, factories being closed down, construction sites being cleared because of an outbreak of COVID. And in terms of the health and social care sector, we see it in terms of full wards being closed. You know, at one point we were looking at, media reports were suggesting a 70% absence rate among, you know, NHS workers. So people who were having to deal with people who have COVID, or who are in workplace settings where it's coming into the workplace, we're contracting it at the workplace. And like any other kind of disease that's contracted at the workplace, you know, we think that that should be, you know, considered as being an industrial disease. I have to say back to the bit about, you know, the lessons to be learned in preparedness. It's quite pertinent, this issue, because only last week, the Scottish Parliament, Scottish Government, etc., in our view, failed to take the opportunity to address this, where there was a bill presented, you know, in the Scottish Parliament, which, given the devolution of industrial injury disablement benefit, there was a bill to set up a Scottish Industrial Injury Disablement Advisory Council, and the Scottish Parliament rejected that. Now, I know that the Scottish Government are going to be consulting on this, and as part of that consultation about the possibility of bringing something forward again in the future, but we think that those kind of bodies would provide an opportunity to recognise long COVID as being an industrial disease. The issue, of course, is going to come down to causation, but there's no doubt in our mind that there are people who have contracted COVID by virtue of their work, of having been at the workplace.
You mentioned what you call REDOR, which paragraph 40 of your statement is expanded to the reporting of injuries, diseases and dangerous occurrences regulations. And I think that's pertinent in this context, because what you say, as I understand it, is that essentially those regulations were not necessarily all applied in the same way by the same employers, and that leaves us with statistics that are perhaps skewed and don't reflect transmission within the workplace.
I think this actually relates as well to the HSE's guidance to employers actually at this during the pandemic, because the guidance that the HSE, according to the TUC report, the guidance that the HSE gave to employers was basically that they don't require to report cases of COVID unless they believe that this was a workplace transmitted case. Now, there's a temptation there for a lot of employers to say, well, it was never a workplace transmitted disease, it's always for the community transmission. Now, you know, you could be cynical and say that a lot of the employers are doing that because they don't want to be sued at a later date. But nonetheless, the stats which are provided for the TUC report bear out that there's a really large discrepancy between the figures that the Office for National Statistics have, particularly with regards to COVID deaths, and what has been reported under RIDOR. I mean, I don't know where I've got this, but I've scribbled on this bit of paper here another just overall statistic. I don't know where it's quoted in here, but just to give you an example, in terms of COVID deaths on the death certificates for people of working age between 16 and 64, now granted they'll not all be working, but for the period April 2020 to April 2021, it's recorded as 126,723 deaths in total for COVID, and 15,263 of those being in that age group of 16 to 24. The RIDOR reporting for people in that age group for the same period is 387. Massive discrepancy between what the death certificates say are people of working age who are contracting COVID, and what RIDOR says are people who have, contracted COVID at the workplace. The health and social care sector was a bit better, it has to be said, than other sectors. Now, in terms of the levels that were reported under RIDOR, that may be due to a couple of factors. One is that the HSE did say at one point that they should report cases where people had been in contact with someone who was infected with COVID. And also there's a kind of general culture, I think, in the NHS in particular, of reporting incidents anyway, in terms of outbreaks or people having, various situations. Having said that, the guidance changed some throughout the pandemic. At one point, the guidance for the HSE was to only report cases where people had become infected by virtue of the face mask being broken or pulled off. So there's no real consistency in terms of how RIDOR is being applied, but the big issue is that employers are being advised to make a judgment call, and they're making a judgment call it's community transmitted rather than workplace transmitted, and therefore not reported. But as I kind of alluded to earlier, we could see in real time that the existence of COVID in the workplace was much greater than what RIDOR was telling us. So we had, in September, even towards the end of the pandemic, we had, the Royal Alexandra Hospital in Paisley virtually shut down most of the wards because of outbreaks of COVID. We had Ayrshire and Arran, testing 200 odd workers getting tested positive, for COVID. With the health and social care sector, as I mentioned, we had food factories being closed, we had construction sites being cleared. And where I think this was an additional problem was that the Scottish Government were, in a lot of cases, were basing their guidance on figures provided to them through RIDOR and the HSE. And therefore, they get a false picture of what the situation is. And in our view, that's what led them to make the error during what is colloquially called the second lockdown, where they virtually exempted the entire construction and manufacturing sector from the lockdown rules. So they were suggesting to us, well, the figures tell us that it's not a major problem on construction sites. At the same time as we know that there's construction sites that are being cleared because of outbreaks in COVID. So what was happening on the ground was evidentially, a much different situation for what the stats being reported through Reader is.
I think at paragraph 44 of your statement, you sum it up at the end there saying it would be safe to assume that the instance of COVID workplace transmission was much higher than the figures upon which the Scottish Government was basing its guidance and restrictions on.
Yes.
Taking you back a bit in your statement to talk about PPE and that issue pertaining to health and social care workers, you start talking about that paragraph 28. And you make a general comment that there was a lack of PPE and what was available was inadequate. You then go into some specifics of what you understood to be the position in relation to particular sectors. And at paragraph 29, you say we had situations at the start of the pandemic where only 1/3 of the ambulance staff were issued with PPE. And I wondered, that particular statistic, are you aware of how you obtained that and where it came from?
Well, the statistics are anecdotal statistic, first of all. And in terms of thinking about where I may have obtained it, throughout the pandemic, I was getting officials of the union, reps of the union, who are feeding things into me and making comments to me. I was also clearly involved in the COVID-19 response group meetings, so I'm not quite certain, whether that came through the reps or the officers or came up during the COVID response group meetings. I'm also not certain whether it might, that people who've reported that to me might actually have been doing so on the back of media reports, because that statistic of 1/3, what the media was reporting was that 1/3 of ambulance workers had contracted COVID, and that was being linked to the lack of provision of proper PPE. So maybe my statement in hindsight would have been better to have said had no access to proper PPE, because we know that to be an absolute fact, that there was ambulance workers who were reporting that they were involved in what's known as AGP, aerosol generating procedures, where they were expected to perform that with ordinary medical masks rather than the double FP3 masks, which would have been more appropriate and necessary when carrying out those procedures. We know that there was ambulance workers who were reporting that the coverings that they were supposed to put on didn't cover their whole uniform and were worried that their uniform was being contaminated. We know that some of them had to put on aprons which were blowing up in the wind. And we know from other health and social care workers that they had similar concerns. And this actually expands beyond the NHS into the care sector as well. I mean, there was certainly cases in the third, particularly in the third and private sector, of workers who were running out of masks and didn't have PPE. Weren't able to access it. There were cases where workers were being advised, I think this did happen in some areas in NHS actually, where workers were being advised to, reuse PPE. In some cases, take it home and wash it, and come back. And eventually that, there was guidance that had to cease. At the start of the pandemic, generally, and I say generally to mean beyond the health, inclusive of, but beyond the health and social care sector, across the economy generally, at the start of the PPE, the provision of PPE, as in the availability of it, rather than the quality of it, was a major issue. I mean, we had this worldwide pandemic which put real strains on the supply chain, and being able to get the levels of PPE that employers across all sectors were saying was required was really difficult. But in terms of that particular remark about the ambulance workers, it's maybe better to qualify that there were media reports that 1/3 of them were tested positive for COVID. That was linked to the non-provision of proper PPE. And those ambulance workers were consistently reporting those issues, particularly around about the non-provision of double FP3 masks, etc.
As opposed to ambulance workers, you go on to talk generally about the health and social care sector, and at paragraph 30 you make an interesting comment that you find it quite odd for there to be a situation in which the sector is predominantly made up of female workers but the equipment is designed for males.
Yes.
Is that something which was reported to you by the membership?
Yes, and in some cases through that, I mean, some of the face masks were designed for, males as well. So, but yes, it was coming up, and we subsequently reported it into the COVID-19 response group that here was a sector, particularly the social care sector, 80-odd% of them, women, and the PPE that was being issued, appeared to be designed in terms of its size, etc., for males. Under the the regs that govern personal protective equipment, it's meant to be, PPE is meant to be suited to the individual who's wearing it, and not just a general. Well, there's PPE. It needs to take account of, you can't have, for example, somebody of a particular height walking about tripping over, a suit that's too long for them, and then they're tempted to turn-ups, and then if there's chemicals or contaminants, it catches in the turn-ups. And there's a whole load of different additional safety issues can arise if you don't have proper fitting PPE. And yes, it was being flagged up to us by members.
You also make comment there that additionally some of the PPE was out of date, and we had cases where presumably it was reported to you that the date had been taped over to cover up that fact. Yes,
yes. And if you look at some of the reports that I mentioned earlier in terms of ambulance workers, some of the media reports on ambulance workers say that was the case for them, as well as for social care workers. But certainly social care workers were reporting that some of the PPE that were being issued was the date was covered over. I mean, I mentioned about the problem with PPE at the start of the pandemic being about the general supply and the impact on the supply chain. I think it would be remiss of me not to also say that a lot of employers, particularly where in social care provision it was profit driven in the private sector, or they took cognizance of profit margins, weren't really prepared for this at all, because they've seen expenditure on these kind of things for something that might never happen, as being a waste of money. And subsequently, as the pandemic rolled on, there would have been pressures on their budgets as well, which again would make it, a kind of incentive for them to look for alternative means rather than the buying in of new PPE. So, in my view, that's a contributory factor to this.
And perhaps we could turn to the section of your statement which says that, I think it's paragraphs 34 to 36, where essentially you're pointing out a difference between the experience of care workers in the private sector as opposed to the public sector, because first of all there's a reluctance to source PPE if there was another way around it.
Aye.
And they were asked to reuse PPE, but also it was used as a substitute for other measures such as social distancing.
Yes, that was often the case as well. Now, don't get me wrong, I mean, in terms of some of the nature of social care work, it's difficult to strictly apply social distancing rules or to determine what is the appropriate social distancing rules because of the nature of the care that is being provided. But maybe because of that difficulty and people having to think things through and plan things out and the time and effort that takes, and what resources you've got in terms of people resource being able to do that, perhaps as a consequence of that, people would look for the kind of soft option where PPE was issued, rather than going through these measures. I have to say, by the way, this was again, just something that occurred in the health and social care sectors. And there are other sectors of the economy, where people jumped, or employers tried to jump to the PPE social distancing, control element, rather than the elimination element. Particularly towards the end of the pandemic, where there seemed to be a push by some employers to get people back in the workplace. So to get them back in the workplace required quite a bit of planning, required quite a bit of expenditure. And when you look at what's known as a hierarchy of controls, they were jumping in a lot of cases, in our view, to issuing PPE rather than some of the other control measures, including social distancing, which could have been put in place.
Turning to your role in communication with the Scottish Government, you speak about that at paragraph 50, and you tell us that you met with the Scottish Government twice per week via the STUC COVID response group, which you've already mentioned. And essentially you say that the personnel at those meetings varied depending on the subject matter of what was being discussed. But at paragraph 54, you're quite positive about that communication, and you say that the process generally worked quite well.
Well, in terms of paragraph 50, I mean, we did meet with the Scottish Government at least once a week. So it wasn't regularly twice a week, but at least once a week. We could have additional meetings in the week if there was particular guidance that the Scottish Government was going to be bringing out, or there was a particular issue which we felt there was a need for, more in-depth discussion. So, for example, we mentioned PPE there. I recall that at one of the meetings with the COVID response group that was taken with the Fair Work Minister at the time, that we thought it would be useful to have an additional meeting during the course of that week with the Government Minister who was responsible for procurement in terms of how they were managing to procure PPE. So that's just one example of how there could be, additional meetings called. I'm generally positive about the fact that the Scottish Government were regularly meeting with us. I'm positive about the fact that on some occasions, no on every occasion, they took on board some of the things that we were saying, and that informed some of the guidance which they subsequently issued. But that's not to say, I describe it at one point as a bit of a mixed bag. That's not to say that everything that we said was taken on board. It's not to say that we're happy about everything that the Scottish Government did or didn't do, but we do recognise that they were taking the time to recognise the crucial role that trade unions could play in terms of not just informing their guidance, but also in terms of challenging, where employers were breaching some of that guidance. So, as I say, it's a bit of a mixed bag, but we do recognise, as I do in the written statement, that recognise the benefits of having those COVID-19 response group meetings. In fact, I think I also say this in the statement. I would go as far as to say that I think they ended too soon as well. I mean, there was this kind of, there seemed to be this, people talk about, when there was COVID, you hear people making that, during the COVID. COVID's never went away. It might not be in the same scale as a pandemic. It certainly isn't having the same effect by virtue, largely, the vaccine minimising, help to minimise the effect on people. But it's still there, and it was still there in fairly large numbers for a period of time. And as far as learning the lessons goes and being prepared, personally, I think it would still be quite useful to have had, periodic meetings just to see where we are. And I think there's a difficulty, having said that, in the sense that I'm a wee bit worried that as part of the preparedness that, do we know where we are? Because one of the things that happened was the closure of the Lighthouse Lab in Glasgow, for example, which was monitoring, the existence of COVID, picking up on new variants, etc. I find it, I don't know if you've ever tried it, but I mean, I find it very difficult to access statistics now about COVID at all. And I just worry that that kind of speed to sort of close the Lighthouse Lab and wind down all the kind of testing facilities has put us in a position that, again, we're playing catch-up. Again, touch wood, it doesn't happen if there's a new variant or there's some other infection comes around. So I just think that these kind of meetings, the COVID response group, having regular testing, having these kind of facilities, were all positives, and keeping some semblance of them, I think, would have been useful.
I wonder if that sense that perhaps things are winding down and are not as important as they once were. You say within your statement, I think, apologies, I'm trying to find it, that I think it's at paragraph 60, that towards the end of the pandemic, a feeling developed that the impact on the economy and also a political impact was becoming more of a consideration than public health. And I wonder, does that tie into the feeling that you're expressing there about things kind of taking a back seat, as it were?
Yes. I think, to be honest, this is a very toned down version of things that we were saying to the Scottish Government at that point in the COVID-19 response group meetings. The Scottish Government were basing their plan, and had been basing their plan on combating COVID on what they called the four harems. You know, its effect on public health, the effect on the economy, the effect on the health service, and the effect on society, including the effect on mental health. And I think, I'll tell you exactly what we were saying to them. We were saying to them that we were getting a bit worried towards the end of the pandemic, that whereas throughout the pandemic public health was the #1 priority in all of that some other considerations, principally the economy, which as trade unionists we're obviously concerned about the economy, but the economic effect and perhaps what was politically positive in terms of how people viewed them were becoming, bigger issues to the point that we were worried that they were overtaking the public health issue, to be honest. So people didn't like lockdown. People wanted to get back into hospitality and socialising, and we wanted workers to be back at work. Whether that was in a hybrid forum or whether they wanted to be back in the workplace, whatever. So people, I can understand where they were coming from, but I just feel, or we felt, that towards the end of the pandemic, these other considerations were, I think the Scottish Government could have continued to be a bit more cautious for a wee bit longer than they did. And in terms of the return, our position in terms of the return to work or to the workplace was that there should have been stronger guidance, I think, on basically allowing more of a kind of voluntary approach from people and more of an onus on the employers to deal with the circumstances and where workers were mentally and physically. So, I mean, if somebody was working well from home and was reluctant to come back into a workplace for legitimate reasons, so perhaps they had family members, who they thought were vulnerable in terms of their, own personal conditions. Or perhaps even there was a mental health fear of going back into the workplace, that rather than force the people back into the workplace, then take this by individual, almost voluntary type of approach to begin with. So you might have somebody else who was desperate to get back into the workplace, who felt the isolation, was something that they couldn't really quite stand any longer, and they wanted to be back there. People like that, how do you get them back into the workplace safely should have been the question, and how do we accommodate getting them in? People who felt vulnerable and who felt frightened, some more time might have been necessary in order to smooth their passage back into the workplace. On the plus side, I think a lot of employers who did take that approach have ended up with a kind of hybrid form of work, which recognises that people are performing well when they're not actually physically in the workplace, but there are still some benefits both to the organisation and to the individual of being in the workplace, and they're accommodating that kind of flexible approach.
Ms Traynor, you've only got 10 minutes.
Thank you, my lord. I am mindful of the time, and there are a number of issues which I think are important to raise with you. One of which you touch on at paragraph 65, and you say that, or sorry, 64, that effectively there was a difference of course between the UK government and the Scottish government guidance, and you say that that posed you issues in relation to some companies who sought to follow the UK position rather than the Scottish position, but also you speak about enforcement of that being an issue, and the feeling that you were being asked to police the situation on behalf of workers.
Yes. Well, in terms of the kind of in terms of the points that you make, sorry, what was the number of the paragraph again?
It's 65, 64 and 65.
64, 65. Right. So we had guidance coming out for the UK government, we had guidance coming out for the Scottish government, and sometimes they differed, particularly in terms of whether people should or should not be working from home at those various points. And we had some employers who would choose to follow the UK guidance, either because they believed that the UK guidance was just the guidance and weren't aware of any Scottish government guidance, or they believed that the UK government guidance took precedence over the Scottish government guidance. And that was particularly the case for companies who might have been UK based rather than Scottish based, and they didn't want to apply different rules and guidance in different locales of where they operated. In terms of enforcing guidance generally, I think this relates to the lack of the devolution of employment law, actually, where I've used the word guidance consistently this morning and throughout the statement, because that's what it was Scottish Government guidance. There was legal, powers that they had in terms of the overall tackling COVID, but when it came to employment law matters, the Scottish Government took the position often that they couldn't enforce certain things. And it was, but we would take the position that they could have enforced some of it, and they could have been stronger with some employers. And sometimes it felt as if it was for us as a trade union to use the word to police it and to intervene. Now that's what trade unions do. I'm not complaining that we had to do that, but it would be better if we were able, and we were more effective intervening if we had something stronger than guidance that were back. When we're getting in debating these kind of issues with employers. There was also, I know I'm Department for Health and Social Care here, but to give you one example, when the schools went back, and school buses, there was social distancing disappeared from school buses, which was a problem because people didn't seem to realise, and including Scottish Government officials until we flagged it up to them, that a lot of school transportation is the dedicated school transport. So I'll take the kids to the school and then it'll go in the general run, right? So you had buses that were taking children to school, sometimes 3 to a seat, right? With no social distancing on it, and then having to go on the general run, where the general run said there was to be social distancing and limited numbers of passengers, and it was being left to the drivers in the vehicles often to police that in both those instances. So when there's kids on the bus who have been unruly, right, and maybe breaking any kind of minimal rules that existed, it was for the driver to enforce it. And similarly, you know, when they're on the general public and people were ignoring social distancing rules, it was for the driver to pull them up, was how we felt. Because there was very little instance of the legal authorities becoming involved in trying to enforce some of these things. And I'll finish on this point on this bit about employment law. Moving forward, I mean, obviously we've STUC and trade unions are in favour of the devilish employment law. But there are things that the Scottish Government can do in the absence of the devilish employment law. And one of the things that it can do is to facilitate the formation of the sectorial bargaining that I mentioned earlier. And I know that through their Fair Work stream that they've looked at this. But in our view, it needs to be speeded up, where the third sector and the private sector, in particular, social care, do get covered by collective bargaining, and we move to sectorial collective bargaining. And we've now got a real immediate situation, because tomorrow there'll be trade unionists at the Scottish Parliament highlighting the fact that although the Scottish Government said that they would put money aside to address sick pay, which just came up here, things like maternity pay and paternity leave, 38 million of the money that they were allocating to that was cut last year, 2023, and in terms of the 2024 budget, there's nothing. So, in our view, we're dangerously moving in the opposite direction. The lessons, one of the principal lessons for the pandemic was how crucial the role is that social care workers perform. They were being applauded on the doorstep, rightly, alongside health sector workers, and there was a recognition that something had to be done about the pay and the terms and conditions that they experience. The Scottish Government moved and agreed to do that, and now appear to be backtracking on it. And this is happening at a time, actually, where we are seeing increasing numbers of social care workers leaving that type of employment. We have care homes closing down because of lack of staff. We have, jobs fairs being held in order to try and attract people into that area of work. And it is linked to the poor pay, the poor conditions, the long hours, the feeling that they're not recognised for the type of very stressful work that they have to do. And I have to say the frustration that, they want to care for the people that they care for, but sometimes they're not given the resources or the time to do it. You've got 15 minutes to be in, to care for that person before you move on to the next one. All of these issues need to be addressed, and that means addressing that question of the missing millions, giving them the £15 an hour minimum that they've been asking for, establishing sectorial bargaining. It means all of those things.
I'm mindful.
Taylor, you've only got 3 minutes.
I know, yes.
If you have more substantive questions that you wish to put to Mr. Cullinane, he has more or less had his allotted hour. I'm afraid he'll have to come back at another date to be continued at that stage.
No, my lord, I was going to conclude. Thank you very much, Mr. Cullinane. I wondered if there was, very, very briefly, any matters which you thought was important to raise that we haven't covered, which can be covered in a short period of time.
Well, I mean, I have raised the stuff about the lessons to be learned in terms of preparedness. I mean, I've covered about pay. We've briefly covered about long COVID.
Yes.
The only thing I would add in terms of the long COVID, and you've heard us say it about we would want it to be recognised as being an industrial disease. This links into the preparedness aspect as well that I mentioned about monitoring where we are. And the kind of general mindset, that COVID has been defeated. Because if COVID cases still arise, which they do, there's always a potential for somebody who contracts COVID to develop long COVID. And if it's not recognised that with the importance it deserves that they've contracted COVID in the first place, then perhaps we'll continue not to get the recognition that long COVID deserves. Because people, by virtue of contracting this, horrible disease, in a lot of cases have been left, with debilitating illnesses and conditions, and that should be recognised, and should be addressed.
I think, Mr. Cullinane, we probably have run out of time there. That's a matter, hopefully, which I think is covered in some detail in your statement. So thank you very much for that, and thank you for your time.
Okay, thank you. And I'm sorry if I've rambled on too long. But
Not at all, not at all.
right. Okay.
Thank you, Mr. Cullinane. Thank you, Ms. Trainer.
Thank you.
2 o'clock for the next session.
Okay, thank you very much.